To all of you. Lacrimal drainage system related surgeries are very commonly performed by oculoplastic surgeons, and I will be taking you through two of them. One is decrocystorhinostomy, and other is trephination. So, starting with the first one, decrocystorhinostomy, as we all know, is very commonly performed with a high success rate of more than 95%. And in this, I will just take you through the overview and then we'll move on to the surgical video. So here we create an anastomosis between the mucosa of the lacrimal sac and nasal mucosa, and opening is created between in the middle meatus. So one thing I would like to emphasize is that the pre-operative preparation of patient for surgery is as important as performing the surgery in itself. So pre-operative workup in a case of DCR is extremely important. You have to control blood pressure. You have to give pre-operative nasal decongestants and rule out any coagulation factor disorders in the patient, which is of extreme importance. While taking the patient to OT, you have to ensure correct position. Head end should be elevated. Nasal packing is a must. You should ensure that you have all the instruments ready, and so that you don't panic while doing the surgery. Anesthesia, we give a transcaruncular block. Blocking the infratrochlear nerve is very important. Then superficial block, subcutaneous we give before starting the surgery. So coming to the surgery itself, the skin incision is made 10 mm from the medial canthus, and after local infiltration, skin incision is made. Thereafter, suborbicularis dissection will be done. These are stay sutures are being placed. Here the injury to angular nerve should be avoided, and suborbicularis dissection is done to expose the maxillary bone and expose the anterior lacrimal crest. Once the bone has been exposed, periosteum will be elevated after giving an incision on the periosteum. Once you have lifted off the periosteum, you can disinsert the anterior limb of the medial canthal tendon, and that is when we will be able to appreciate the lacrimal sac clearly. As we can see, anterior lacrimal crest, lacrimal fossa, and lamina preparatia, the suture line between the lacrimal bone and the maxillary bone. And this will be the site where the osteotomy is initiated, and now the Kelly's bone punch is used to enlarge the osteotomy. The boundaries of the osteotomy that we create are extremely important for the future prognosis of the patient. Anteriorly, 5 mm anterior to the anterior lacrimal crest, we can enlarge the opening inferiorly up to the nasolacrimal duct, posteriorly up to the at the start of the lamina preparatia, and superiorly up to the medial canthal tendon. Now the punctum is being dilated, and so once we have inflated the sac with viscoelastic, we are now creating lacrimal sac flaps using a 2.2 crescent. So once the flap, now we can see the nasal mucosa flaps as well. Once both the flaps have been created, posterior flaps can be sutured to the posterior flap and anterior as well. Placing a silicone intubation tube is not really helpful in the cases where patient has presented to us with for the first time. In failed cases, it might be of some help. So once we have anastomosed the lacrimal mucosa flaps with the nasal mucosa flaps, next we will do the layered closure, first closing the orbicularis and then the skin. So once the surgery has been done, you have to take proper post-op care of the patient, complete bed rest, propped up position for 24 hours. Do not remove the nasal packing before 12 hours after surgery and give oral analgesics to the patient. Next, moving on to the another commonly performed surgery, that is trephination with monocanaliculaire stenting. Usually monocanaliculaire stenting with mini monoca stent is indicated for canalicular blocks. The success rates have been reported more in cases with distal canalicular blocks. So this is how the surgery is performed. Video credits go to Professor Bajaj. After local infiltration, puncta is being dilated. And after dilating the puncta, we'll use a Bowman's probe to measure the site of blockade. As we can see here, it comes out to be almost 10 mm. That suggests that the block in this case is at the level of common canaliculus. Then the trephine is introduced, and once the trephine reaches the site of blockade, the stylet is removed, and then gentle rotatory motion is initiated to release the block and introduce the trephine up to the lacrimal sac. And once you have reached the sac, you can confirm the release of blockage by doing the syringing through the same trephine. As in this case, the syringing is being performed. And once we confirm that the passage is patent now, we can now place a monocanalicular stent. So this is the mini monoca stent with which is usually cut to make a beveled edge, so for easy introduction. And once it is introduced, the hub of the stent is snugly fit into the puncta, and there is no need to suture it usually. So thank you.
Thank you, Dr. Parag. So I think discussion we can keep for the end of this session. So now we go on to the next talk by Dr. Mrinalini. She'll be showing some interesting videos on contracted socket reconstruction procedures.
Good morning, everyone. Let's delve into the contracted socket management now. We all know what contracted socket is defined as. It is shrinkage and shortening of all or part of orbital tissues, which causes a decrease in the depth of the fornices and orbital volume, ultimately leading to inability to retain the prosthesis. What are the characteristics of a contracted socket? There is loss of conjunctival surface. There may be a deep cicatrix formation, atrophy of the orbital fat, fornix contraction and volume loss, a deep superior sulcus formation, pseudotosis of the upper lid, and lower lid malpositions. Now, there are many classifications. We'll talk about Gopal Krishna classification and Byron and Smith classification. Gopal Krishna classification only focuses on the surface contracture and not the volume. So grade 1 is when one or the lower fornix is present. Grade 2 is when upper and lower fornices are shortened. Grade 3 is all fornices are shortened. Grade 4 is all fornices with reduction of the palpebral aperture. Grade 5 is recurrence of socket after repeated trials of reconstruction. So, Byron and Smith classification also takes into account the volume and the bony contracture. So if there is along with loss of area and volume, there's also loss of volume, we characterize as a severe contracted socket, and along with bony contracture, we call it malignant socket contracture. So in mild socket contracture, what are the options that we have is you can just put a fornix formation suture. If you have moderate to severe contracted socket with loss of only the surface area, you can replace it in mild to moderate with an AMG and moderate to severe with an MMG. If you need a larger replacement, even a split thickness skin graft can be used. But if you want both also the surface and the volume correction together, then you should opt for a dermis fat graft. And obviously we are here talking about only vascular socket, not an avascular socket or irradiated sockets. None of these will work. You'll have to use a vascular pedicle graft. Okay, now if you want to differentiate if there is a moderate surface area loss to a severe surface area loss, what you can do is a probe test. You can take a wet cotton tip and press on the inferior fornix. If there is just shallowing, that indicates it's a moderate contracted socket. While if there is a shift, if you notice, then that means there's a severe loss of surface area. So let's look at the videos. I'll be showing AMG, MMG and DFG. So if there is mild to moderate surface area loss, then we do an AMG. Here what we are doing is, first of all, you have to measure, the how much inferior fornix you want to form. So usually inferior fornix is about 12 to 14 mm, so we can take a 15 mm mark, make an incision in the conjunctiva, then now we are dissecting it from the inferior fibrous tissues, and then at whatever depth you aim to form the fornix, you have to pass the fornix formation sutures, taking it out from the periosteum and then the skin surface. And you can place 3 such sutures. So here we've passed the first fornix formation suture and taking it out with a peg or a bolster. So we formed the fornix. Now the bed is also formed after dissection, and now we are placing the AMG and gently unfolding it with the epithelial side up. So here we are placing the AMG in the bed with the help of fibrin glue. So you dry the surface, you apply a thin layer of glue and gently tuck in the AMG. And all you need to do now is put the anchoring sutures. So we'll put one here, one here, one here and one here. After the anchoring sutures are put, you have to place a conformer and see if the lid apposition is proper and the conformer is in the center. It should be an appropriately sized conformer. Then you place a temporary median tarsography which will be there for the next 6 to 8 weeks. Now going into mucous membrane graft, video courtesy is Dr. Rachna. If you have a moderate to severe surface area loss, as we can see here, the inferior fornix is shortened, the superior fornix is shortened. So here we opt for a mucous membrane graft. So again you make an incision in the center, you dissect the conjunctiva from the underlying fibrous tissues, and then you form 2 flaps of the conjunctiva to which you want to make the inferior and the superior fornix with. Again we are passing fornix formation sutures. After that you have to measure how much gap is there, how big the bed is, and take an oversizing of about 25 to 30% because of the primary contracture that will happen. Now we are going to be harvesting the mucous membrane graft. So you take a 25 to 30% increase in size, and you have to make sure that this wherever you're placing your mark, it should be anterior to the frenulum. Then you inject a 2% lignocaine with adrenaline injection. This will obviously provide anesthesia as well as provide a dissection plane and decrease the bleeding. You should be in the correct dissection plane, otherwise there may be more bleeding. So after you mark, then you have to give a very superficial incision and then dissect it from the underlying bed. So we've harvested a nice thin MMG here. Then second is you prepare the AMG. Whatever excess fat is present, you have to take it out so that the graft uptake is proper and the graft becomes vascular early. Now here what we're doing is we are meshing the graft. We are giving full thickness incisions through the graft to increase the surface area. Now our bed is created, we've dissected it properly, we formed the fornix. Now we are going to place the graft in the bed. Again, first anchoring sutures, and then you can suture around it, or you even use a glue to place it. So we are suturing the MMG in the bed all around. Then in the end you have to place a conformer, again an appropriate size conformer, and put a temporary tarsography. Next, what I'm going to discuss is dermis fat graft, which the advantage of a dermis fat graft is that it provides orbital volume as well as the surface area. And preferred donor site what we take from is the upper outer quadrant. You draw a line from the middle, from the anterior iliac crest to the ischial tuberosity, and at the midpoint 5 centimeter below it is where you take it from, because there is a non-weight bearing, non-hair bearing area which will provide you with the amount of fat that you need. With your courtesies, Professor Neelam Pushkar. So here you can see this is a severely contracted socket. There are deep cicatrizing bands present. Again, we are making the incision in the conjunctiva and dissecting it from the underlying fibrous tissue. After we've dissected it aptly, then we are going to form the fornix again pass the fornix formation sutures. After we've prepared the host site, now we are going to take out the DFG or harvest the DFG. So you make a semicircular incision which is about 20 to 25 mm in length at the upper outer quadrant, as I told, and then make a very superficial incision with a 15 number blade, because you'll be only taking out the epidermis or the epithelium here. Gently dissect it out from the underlying dermis. This fibrous tissue that you're seeing is the dermis, and if you're seeing these pinpoint bleeding spots, then you're in the correct plane. Then you give a deeper incision with the same 15 number blade and take out the fat. You have to make sure that you take more fat, because you know, as we know, that there's 40 to 50% fat atrophy that occurs. So here we've harvested our dermis fat graft. Now we have to close this site. So first we are undermining the skin so that the closure happens without the tension, and then we are closing it in 2 layers, first with a 6-0 vicryl and then with a 4-0 silk in a in a horizontal mattress suture. Now we are going to be placing the dermis fat graft in the host site. So you have to snugly fit it, and then you have to suture the conjunctiva with the dermis. You have to make sure that there is no conjunctiva buried inside, otherwise it will lead to formation of inclusion cysts. So we are suturing the dermis fat graft that we have harvested with the conjunctival flaps that we created. Now it's placed and sutures are done. Again, we'll place a apt size conformer and put a tarsography suture. Okay, so here summarizing is we have a flow chart to guide us in the management, that if a patient comes to you with a shallow fornix but there is no surface or volume loss, you can advise for a customized prosthesis or just put a fornix formation suture. If there is surface loss but there is no volume loss, if it's only mild, you can do a fornix formation suture with relaxing incision. If it is moderate, you can put AMG with a fornix formation suture. If it is severe surface loss, you can put MMG with fornix formation suture. And if there is surface as well as volume loss, there are 2 options. One is a dermis fat graft, the other is you use a secondary implant with a mucous membrane graft. But if there is poor vascularity, then you have to do a vascular pedicle graft. Thank you.
So thank you, Mrinali. Very well presented and very nicely shown video. So I now invite the next speaker, Dr. Asmita. She is senior resident in Unit 5. She will be speaking on essentials in managing in entropion and ectropion. Dr. Asmita.
Thank you, sir. Um, Good morning, everyone. So I'll be discussing eyelid malpositions, both entropion and ectropion. Coming on to first entropion. In entropion, there is an inturning of the eyelid margin. Mainly, it can be involutional, congenital, cicatricial, or spastic. Most commonly, for upper lid entropion, we see the cicatricial cases. They are mainly sequelae of SJS, chronic blepharitis, trachoma sequelae. That leads to scarring of the palpebral surface, and that leads to an inward turning of the eyelid margin. Kemp and Collin has given a classification dividing it into minimal, moderate, and severe. Minimal entropion is present when there is just a migration of the meibomian glands. There is an inward turning of the eyelid margin, and there is lash globe contact on upgaze. Moderate is specified when there is a lash globe contact in primary position as well, leading to some lid retraction. Severe entropion is present when there is a modification of the lid margin surface, leading to metaplastic lashes formation, presence of keratin plaques. How do we differentiate moderate and severe is that basically due to severe entropion, there is shortage of the palpebral surface and the patient develops lag of thalamus in the primary position and the lid is not able to close properly. Accordingly, we have defined surgical management for these patients. For minimal cases, we go ahead with an anterior lamellar repositioning. In this case, what we do is that we make I'll be discussing surgical video subsequently, but for minimal cases, we make a surgical incision. We pass sutures through the superior surface of the tarsus and take it out from anterior to the lash line, and we reposition the anterior lamella by pulling it upwards. In addition, we can add a gray line split, which will augment the effect of our surgery. For moderate cases, we go ahead with a tarsal wedge resection, or we can divide the lamella and advance the posterior lamella. For severe cases, we usually do a tarsal fracture with rotation of the terminal tarsoconjunctival segment. Or we can go ahead with the posterior lamellar graft to lengthen the posterior lamellae. The surgery that we will choose will depend on what is the clinical presentation of the patient. If the posterior lamella appears shortened and the patient's main complaints are of lag of thalamus, we need to lengthen the posterior lamella by providing it with a MMG or any other surface replacement. But if the main complaints are that the patient has a lot of keratin and metaplastic lashes on the tarsoconjunctival surface, then we will go ahead with the tarsal fracture with rotation of the terminal tarsoconjunctival segment. Coming to the first surgical video of anterior lamellar repositioning, surgical videos have been provided by Professor Neelam Pushkar and Dr. Rachna Meel. In this surgery is mainly done in minimal cases of entropion, upper lid entropion. Let me be very clear that cicatricial cases are seen in young patients and involutional cases are seen in older patients, and anterior lamellar repositioning is done for cicatricial cases of the upper eyelid and minimal cases. These surgeries are not applicable to lower lid entropion corrections. So what we do is that after making a surgical incision at the lid crease, we dissect the superior surface of the tarsus and reach up to the anterior lash margin, and then we pass and after making this lid crease incision and dissecting it, we have exposed the anterior surface of the tarsus all the way up to the anterior lash margin. We pass a suture from the superior surface of the tarsus, making sure that it does not go full thickness to the conjunctival surface, and then take out the suture from the anterior lash margin. Three such similar box sutures are passed, horizontal mattress sutures, and we can secure them using a bolster or a peg. What this will basically do is that it will rotate this anterior part of the lash margin superiorly, leading to this inward lash turning margin to move outwardly. This is what the surgery will do. In addition, if you want to augment the effect, as we can appreciate, if we split this lid margin at the gray line, the effect of this rotation would be much more. So this is the surgery which we do for minimal eyelid entropion. Moving on to the tarsal fracture that we were discussing for severe entropion. In this case, what we do is after passing the cotton sutures, after rotating the upper eyelid over a lid spatula, we make an incision in the sulcus subtarsalis, which is about 2 millimeters inside the eyelid margin. After exposing the tarsal plate, we pass sutures from the tarsal plate, and then they are taken out from anterior to the lash, from the skin surface just above the lash margin. As close as we are to the lash margin, that is, the amount of effect will increase. And after that, we can use these bolsters or pegs, or we can just directly suture the silk sutures to the above the lash margin. What this will help in is that it will tighten this area, and the superior small segment, the 2 millimeter tarsal segment that we have cut off, will rotate along with the tarsoconjunctiva, and it will move to the anterior side. Coming on to involutional entropion, which we usually see in elderly patients. In involutional entropion, there are 4 main pathophysiologies which are coming into action. One, there can be an overriding of the preceptal muscle, there can be a horizontal lid laxicity, and there can be a disinsertion of the lower lid retractors, or there can be atrophic changes in the tarsus. Depending upon which particular pathophysiology is particularly active in that patient, that is how we will decide which surgery to choose. V's procedure is usually chosen when there is an overriding of the preceptal over the pretarsal muscle fibers. Coming on to the surgical video, we will give an incision near the lower border of tarsus, about 4 mm from the lid margin, and after incising it, we can give a full thickness incision all the way up to the conjunctiva. We will pass sutures from this lower border of lower skin incision, passing from the lower border of the tarsus and coming anteriorly, so that a surgical scar is formed, which will prevent the overriding of the preceptal muscle over the pretarsal muscle. In addition, we can give everting sutures to augment our surgery. Coming on to plication of retractors, this is usually done in cases in which we feel that there is a disinsertion of the inferior eyelid retractors. How we will confirm this finding is that when we can see that on retracting the lower lid, there is a disinsertion of retractors in between the cul-de-sac. We can see the orbicularis muscle protruding from the lower border, near the lower border of tarsus, indicating that the lower lid retractors have disinserted at that point. Coming on to the surgical video. After giving a 4 mm incision below the lower lid margin, we will dissect and reach up to the lower lid retractors below the orbital septum. How do we confirm that we have seen the lower lid retractors and we are sure that we are plicating the correct thing is that we can ask the patient to look down on the surgical table, and along with the inferior rectus, the inferior retractors are also pulled down, and that movement can be appreciated on table. That is when we are sure that we have, I think the surgical video is restarting. Yeah. So going beneath the orbital septum, we will look for the inferior lid retractors and pass sutures from the skin, then through the inferior lid retractors, and take it out over the skin surface. This would be the effect that would be created, that lower lid retractors which have disinserted will now be reinserted back to the lower border of the tarsus surface, and they will be plicated, leading to a correction in the eyelid margin position. 2 to 3 such sutures can be passed. After that, we will just close the skin surface. Moving on to ectropion, it is basically an outward turning of the eyelid margin, mainly seen in involutional cases. Again, you will have to identify which particular pathophysiology is most active in this patient. Depending on that, we will decide a surgical procedure. Describing one of these procedures, the lazy T procedure, which will correct both the medial ectropion along with the excessive lid laxicity. So for the correction of the excessive lid laxicity, what we do is a pentagon excision that will remove the excess tissue that is present in the lower lid. Along with that, what we do to correct the medial ectropion is that we do a medial canthoplasty. What we do is that we make a diamond incision in the medial part of the conjunctiva, and then when we are passing sutures, we take the lower lid retractors and the lower border of tarsus, and we suture them together, pulling it inwards. So the lower lid margin, which was now protruding outwards medially, will now be pulled inwards. And why is this surgical procedure called lazy T? Is that after we close this incision, we will get a horizontal incision where we are correcting the medial using the medial canthoplasty, and we will get a vertical incision where we are correcting using the pentagon excision. That is why it is called a lazy T procedure. So this is what I meant by we make a diamond incision, and when we are suturing it, we pass sutures through the lower lid retractors, through the low border of tarsus, and bring it out towards the superior end of our diamond incision. After that, we close the pentagon excision to remove the excess tissue. Thank you.
Thank you, Dr. Ashmita. Now we move on to the next speaker, Dr. Bhupendra. He'll be talking about approaches to ptosis correction.
Thank you, ma'am.
You need to stick to your 5 minutes time, maximum
ma'am.
7-8 minutes,
Thank you.
not more than that.
Good morning, everyone. I'm going to present the techniques in ptosis correction. Ptosis is the most common condition we encountered in our oculoplastic clinic. It is important. It is important to know the anatomy of the eyelid before we proceed to the surgical part of the surgical part. LPS is originated from the lesser wing of the sphenoid, and it travel horizontally. Initially, it travel horizontally. It is around 35 to 40 mm. Its horizontal part, which is a muscular part, and then it travel vertically, which is appendage part, which is around the 15 to 20 mm of the LPS. Vitreous ligament is act as a suspensory ligament of the further upper eyelid, and it act as a fulcrum for the LPS muscle. Lid is anterior to posterior, lid is divided into anterior lamina and posterior lamina. Anterior lamina is divided into the skin and the orbicularis, and posterior lamina at the level of tarsus is divided into the tarsus and the conjunctiva. And superior to the tarsus, the posterior lamina consists of the orbital septum, LPS molars, and the conjunctiva. Choice of the surgery depends on the amount of ptosis and the LPS section, and there is any response to phenylephrine or not. And there is also an important role of Bell's phenomena, age and vision. We are going to present the clinic scenario. In this patient, which is a 28-year-old female, patient present with the left eye congenital simple ptosis with MRD is around -1, which is a severe ptosis, and LPS section is around 5 mm, which is fair LPS, and there is good Bell's phenomena. We are planning to do the maximum LPS resection for this patient. Video courtesy from Dr. Ashram. Lid crease height is measured in the opposite eye and marked. Lid margin is marked in relation to corneal right reflex, median and lateral limbus. And we pass the traction suture and we incise the skin at the level of lid margin. Dissection is carried out in the suborbicularis plane. Orbital fluorescence occurs when the septum is breached. Superior border of the superior surface of the tarsus is exposed. Now we inject the 2% lignocaine in the subconjunctival space, so we create the ballooning of the LPS. LPS molar measure complex distension from the tarsus. Distension carried out to separate the LPS molar muscle from the conjunctiva, and the medial and lateral horn of the LPS is cut. Desired marking for the LPS is done, and suture bias taken at the same level and suture to a superior anterior part of the tarsus. Check whether the desired elevation is achieved or not. Another suture placed lateral to the suture, and at last we suture the skin with taking the bite from the LPS to create the lid crease. And the last, we flow suture is applied. This is a post-op picture of the patient. This is another clinical picture. In this patient, in this 10-year-old male patient, the left eye is congenital simple moderate ptosis with MRD around 0 mm, with 3 mm ptosis, and fade to good LPS section of around 7 mm. There is good bells. We plan for LPS plication of 15 to 18 mm. Initial steps are same in both LPS resection and plication, so we are going to skip that part. Initial part are similar in the LPS resection plication, so we skip that part. After breaching the orbital septum, the preoperative fat is pop out, and we make the desired marking. And partial thickness bite is taken from the any anterior superior border of the tarsus, and then from the LPS suture. Initially, we take the center suture, which is important for the desired height of the post-op period. Then we take the lateral, then we pass the suture from the lateral. Then we take the suture from the medial side of the initial suture. Initially, we apply the temporary suture, temporary knot. So we can decide the appropriate height is achieved or not. Then in the last we apply the permanent knot, and we close the skin. This is a post-op picture of the patient. Another clinical scenario is a 19-year-old female patient present with the left eye congenital simple.
Dr. Vipender, we're running short of time. You can
Yes.
kindly conclude your part.
Yes, sir. This is a levator resection through the conjunctive approach. It is video is taken from Professor M.S. Bajaj.
I think you can conclude, Bhupender, because
Yes, ma'am.
there are many more speakers, you know.
Yes, ma'am. The choice of the surgery is depend on the amount of ptosis, the LPS action, and the bisphenol is poor and good. Thank.
Okay, thank you, Dr. Bhupender. And moving on to the next speaker, we have Dr. Sahil. He will be speaking on the role of Botox in oculoplasty. And I request all the speakers to kindly stick on 5 minutes since we are running short of time. Thank you.
Very good morning to everyone present, respected chairs, and my colleagues and seniors. So I will be presenting this talk on botulinum toxin and oculoplasty. Next functional nahi hai button. Sorry. So I have no financial disclosures for the presentation. We all know that the botulinum toxin is excreted from this bacteria, Clostridium botulinum. It is a gram-positive anaerobic spore-forming bacillus. It causes varying degrees of self-limited flaccid paralysis. However, the toxic doses being 0.09 to 0.15 micrograms is 100 times higher than that found in a 100-unit vial of a Botox. So Botox is a trade name. It's not botulinum toxin. Botox is a cosmetic. It's a product by a company. So how do they act? They basically act at the neuromuscular junction of cholinergic nerve endings, wherein they cleave SNAP25 and inhibits the release of acetylcholine into the neuromuscular junction. So this causes the flaccid paralysis. The effect starts right at 2 to 3 days after the injection, peaks at about 14 days, and the duration lasts for around 3 months. Post which there is muscle recovery by sprouting of the new terminal axons. So the use of Botox in ophthalmology started right back in 1980 when Scott first used it for strabismus. Later on in 1989, it was approved by the FDA for use in strabismus, BEB, benign essential blepharospasm, and hemifacial spasms. In 2002, then it got FDA approved for aesthetics, especially the periocular aesthetics area. Besides this, at our center, we also use it for eyelid retraction cases for lacrimal hypersecretion. So we need to know 3 or 4 muscles, origin and insertion, for knowing the clinical application of Botox. So of this, the occipital frontalis muscle, which has 2 bellies, the occipital part and the frontalis part. The frontalis muscle has 2 bellies there. They start from the superficial fibers of the periocular muscles, the orbicularis oculi. The procerus and the corrugator supercilii run upwards laterally in the 2 bellies and get inserted into the gallia aponeurotica of the scalp. Then we have the procedure sitting right in the middle, in between the 2 eyebrows. So it gets its origin from the superior part of the nasal bone, as well as from the upper lateral nasal cartilage, runs straight up, becomes superficial and gets inserted into the skin. Also gets merged with few fibers of the frontalis muscle there. Then we have 2 corrugator supercilii which run upwards and laterally. They start from the superior ciliary ridge, the frontal ridge, and then run upwards and laterally. Laterally, they become relatively deeper. They also merge with the fibers of the orbicularis oculi and the frontalis muscle. And then we have the orbicularis oculi originating right from the middle part of the orbital margin, running all the way around the orbital septum, both superiorly and inferiorly, getting inserted laterally into the lateral palpebral raphe. So if we all frown, if we all get angry, get super angry, we frown, right? So we can palpate the corrugator muscle. This is the corrugator muscle present all along, and the centermost part, this bulky area, this is the procerus. And whenever we ask the patient to look up, so this is the frontalis which is causing the crease to be formed. Another important aspect of giving Botox is this reconstitution. Each vial of Botox contains 100 units of type A neurotoxin, which is vacuum dried form without a preservative. It should be cold storage. The cold storage is very important to prevent its potential from being lost. It should be stored at -5 degrees Celsius. Once reconstituted using preservative-free saline, should be used within 4 hours. And also, after reconstituting with preservative-free saline, the reconstitution should be in such a way that you not turbulently roll it. It should be gently swirled so that it doesn't lose its potency. Besides that, we should also always check for the vacuum of the that the bottle is sealed. How do you check that? Is basically once you insert in the needle inside the bottle, what would happen is because of the vacuum presence inside the bottle, the botulinum toxin inside the syringe, the saline in the syringe would itself be dragged inside into the bottle because of the presence of vacuum. So this would indicate the bottle was sterile. Let's start with the cases. Let's start with the applications, clinical applications of botulinum toxin. So blepharospasm is an involuntary and repetitive bilateral spasmodic contraction of the orbicularis oculi muscle. So this this video for injection of Botox for blepharospasm, we had this 68-year-old elderly female presenting with bilateral blepharospasm in which we can see the orbicularis oculi is totally involved in both sides. So first we need to mark the sites where the Botox has to be injected. Basically, it would be the medial and the lateral aspect of the upper lid, and the lower lid, the lateral aspect. Besides it, we may also inject in severe cases in the midpoints of the upper as well as the lower lid. The injection at this sites, while giving the injection at this sites, we should be careful that the direction of the needle should be away. It should be loaded in an insulin syringe with 27 gauge needle. The direction of the needle away from the lid margin. It should be 45 degree to the lid margin, and we should say superficial. In the subcutaneous plane, should not go deep, and in the pretarsal space, not in the preseptal. So going deep and in the preseptal space would cause ptosis for such patients, because you'll go and somewhere provide the botulinum toxin to the LPS rather than the orbicularis oculi. And the dose at each site could depend on the amount of retraction, the amount of spasm they generally have. Such patients generally respond to around 2.5 to 4 units of botulinum toxin at each site. In cases which also have a associated hemifacial spasm, we need to target two more muscles, the zygomaticus major and the levator labii superioris aliqui nasi. So the zygomaticus, for the zygomaticus major, we inject under the prominence of zygoma. This is the prominence of zygoma. Right underneath we inject here, and again away from it. And for the levator labii superioris aliqui nasi, we target the inferior medial to the nasolabial fold. For Botox and lacrimal injection, courtesy Professor Mohammed Bajaj sir for the video, we asked the patient to look inferior medially downwards. The lacrimal gets prolapsed, and we directly inject Botox into this prolapsed lacrimal gland, straight into the substance of it, both in the palpebral part and the orbital part. Going very deep might cause ptosis in the coming weeks. So, and diplopia happens very rarely. Just coming to this last video, lid retraction, wherein I thank Dr. Neela Pushkar ma'am for the video. After retraction of the eyelid, this was a case of a young female with upper eyelid retraction due to thyroid eye disease. The lid retraction was stable for the last 6 months. After putting in topical piropenicillin drops, the lid is everted and botulinum toxin is injected along the superior border of the tarsus. So the upper lid everted, superior border of tarsus, we hold the conjunctiva and it's with the Vanna's forceps and inject in the subconjunctival plane at 2 points, basically centrally and laterally. The central point being the maximum bulk of the muscle, and the lateral point especially because in cases with TED, there is a lateral ferrand which would help in getting the lid down. The amount of injection, the amount of unit that is to be placed at each site would depend upon the amount of retraction generally the patient has. I'll just quickly go through this last video on Botox and periocular aesthetics. We had this 53-year-old male with this 11 lines, which is caused because of the procerus and the corrugator supercilii. This bunny lines caused by the nasal muscle or the nasal bridge, and the crowfits caused by the orbicularis oculi. So, going very fast, for the procerus and the corrugator muscle, we ask the patient to make the function, make the muscles into action. We ask the patient to give dynamic crowding of the muscles by asking him to frown very angrily, and then we palpate the bulk of the muscle. For procerus, the injection is given right at the center. It's a line. It's roughly a line between the middle canthus, joining with the middle end of the eyebrow of the other eye, and another line crossing from the middle end canthus of the left eye to the middle end of the eyebrow. The centermost point of this is the point where the bulk of the procerus should be injected into. And there are 2 points for the corrugator supercilii. One just medial to the midpoint of the eyebrow, and the other one would be where it should be medial to the mid-pupillary line, so that we do not have a lateral eyebrow droop, and should also be not much beyond where the main bulk of the muscle is present. The bulk of the muscle again can be checked by asking the patient to frown. And coming lastly to this frontalis muscle for the forehead creases, basically There's this traditional technique, I'll just cut short it. There's this traditional technique of injecting it in an M-shaped fashion, wherein we palpate the lateral temporal creases. These are the lateral ends of the frontalis muscle, and then inject it in an M-shaped fashion. The first 2 points are 1.5 to 2 centimeter medial to this temporalis crest. We divide the forehead into 3 halves. No, we do not give in the lower half. We inject in the upper and middle halves. And above, these are the two first points, 1.5 centimeter, 2 centimeter medial to the temporal crease. And the midpoint of this is the third point. And then we inject just below the uppermost crease that the patient has, 0.5 centimeter below the uppermost crease that the patient has, in between the first and the third point here, and the third and the fifth point here. So with this, I would just like to thank the chairs for allowing me to give this talk. Thank you so much.
Thank you, Dr. Sahil, for wonderfully explaining all the important points. Now we move on to next talk by Dr. Suman. It's my request that please skip the theory part and come to the videos straight away, because we are already, running short of time. She'll be talking about lid reconstruction procedures. We have Dr. Bhavna. You can invite her.
Good morning, everyone. I'll be telling you the tricks of the trade for eyelid reconstruction. So the choice of surgery for eyelid reconstruction depends on the size and the extent of the defect. The
Please come to the videos.
Yes, ma'am. So my first video is tensile semicircular flap, which you can use in a medium sized full thickness defect of around 25 to 50%. So coming to the videos, I thank Professor Neelam Pushkar ma'am for providing me this video. This is a child with congenital coloboma of 50% defect. So in this we plan for tensile semicircular flap. A semicircular flap is created, semicircular mark is taken, and then we make sure that when we are giving the cut, we orient that also along the semicircular mark, and then so this is the orientation of the cut, which should be along the mark, and then we mobilize the conjunctiva and then close the lid defect. After freshening up the margins, we should make sure that when we are passing the vertical mattress suture, the first bite should be taken through the meibomian gland, so that there is a good skeleton strengthening which is provided when you are taking the bite, and then the skin defect is closed using the 4-0 silk sutures. My second surgery which I am going to show is Cutler beard flap. It's a 2-stage procedure. This is done when the defect is more than 50% and it's a upper lid defect. So this is a child with upper lid coloboma in an abortive cryptophthalmos. So we can see a sheet of skin which is adhered to the cornea. So in this we had released this adhesion and placed the AMG as well. So the first step is to take a mark which should be at least 4 mm from the lid margin. This will ensure that you are not damaging the inferior marginal arcade as well as the tarsus, and this will provide the vascular supply for the flap which you are creating. After giving a full thickness cut in the inferior lower lid, you take the flap through the defect which we have created and then suture. Here we can see that we have placed the AMG as well. So after pulling it through the full thickness defect, you do a layered closure where you suture the conjunctiva with the upper lid conjunctiva and the skin with the upper lid skin. Since This is child. So for this patient, we have released the flap at 3 weeks, but normally it should be done at 6 to 8 weeks of duration. The next video is a mustarde cheek flap. This is preferred in patients where the vertical height of the defect is large, which is almost reaching your ala of the nose. So this was a 60-year-old female male with lower lid squamous cell carcinoma. So the first thing is to mark the point till where you have to remove the carcinoma, and after seeing the defect, you should ensure that this part is as vertical as possible. Then you take a mark which goes semicircular in the upper part and then reaches the pinna inferiorly, then dissecting the plane. It is important while dissecting that you stay in the subcutaneous plane. That is, the fat should be above and below your instrument, and you should not go deeper. And after that, sorry. After that, you rotate the flap and take the bites, which are and ensure that there is no tension when you are taking the bites. That's it. Thank you so much.
Thank you, Dr. Suman. Next, I invite Professor Bhavna Chola. Ma'am will be showing the videos on plaque brachytherapy for ocular tumors.
Okay, so I'll just take a couple of moments to load my presentation here. In the meantime, if you have any questions for the previous speakers, I think that will save time.
Which one?
So we can take some questions from the audience, please. Any questions? Any clarifications or any suggestions?
All right, so I have kept it very brief, very short. I'm just going to talk about plaque brachytherapy for intraocular tumors here. So thank you very much. I'm honored. So just beginning with a brief description of the case that I'm going to show. This was a 57-year-old male. He presented with the diminution of vision in the left eye. It was 6 by 60 at presentation. And here you can see the fundus image. It's an elevated dome-shaped mass arising from the choroid. It's in the inferotemporal quadrant. It's involving the macula, and there's overlying orange pigment deposits. The ultrasound shows a hypoechoic dome-shaped intraocular mass with moderate amplitude spikes with a positive kappa sign. Apical thickness was 3.9 mm and a large basal diameter the largest basal diameter was 10.2 millimeters. This is the fundus autofluorescence picture. Here you can see clumps of hyperautofluorescence correlating with the orange pigmentation that we saw on clinical examination. This is the FFA picture showing a patchy fluorescence in the early phase of the FFA and staining and leakage in the late phase of FFA. This is the ICG that was done. Hypofluorescence seen in the early phase, mild hypofluorescence seen in the late phase. This was the OCT picture. We have a smooth dome-shaped surface with subretinal fluid choroidal shadowing with shaggy loss of photoreceptors. This was followed by an MRI of the brain and orbit because we were suspecting a clinical diagnosis of a choroidal melanoma. So we went ahead with MRI and it confirmed the diagnosis. You can see both the T1 weighted and the T2 weighted axial cuts. The T1 showing a lesion being hyperintense and T2 weighted a hypointense lesion. Further on, to rule out metastasis, we did a FDG PET CT scan. It showed a nodular choroidal thickening along the posterior chamber of the left globe. There was no other hypermetabolic lesion anywhere else in the body. So here we have a case with a diagnosis of choroidal melanoma in the left eye, and the plan is to do plaque brachytherapy under local anesthesia. So that's a brief description of the case. And then now I'll just go on to the video. Can I have the video, please? It's again in the folder here. Right. So there we have, so this is what we do in the OT. We have a dedicated OT setup for plaque brachytherapy following all the radiation safety protocols that are approved by the Radiation Safety Board. So intraoperatively, we are confirming our ultrasound findings, and this is what we get to see. This, of course, are the instruments that are being used. What you see here is the dummy plaque, which is first used, and the sutures are placed before we put the radioactive plaque. So as you know, in this case, it was an inferotemporal location of the choroidal melanoma. So the peritomy was done in the appropriate quadrant. Here you can see that the lateral rectus is being secured. Now, in this particular case, we actually had to dissect the lateral rectus because, as you saw in the case, the mass was, inferotemporal in location, and we also had to put the plaque in that quadrant, so we needed space for that. But it's not every time during surgery that we have to disinsert the muscles. It depends on the location of the tumor. Here we are confirming the location of the tumor after putting the dummy plaque, that it is the plaque is located well over the tumor. This is like, you can see that the sutures now are being placed onto the sclera. This is the 5-0 ethibond suture, which is being passed through the scleral thickness out here. So we'll be using two anchoring sutures. So once we have passed these two sutures through the sclera, we know that we are in the right place, and then we can actually put the ruthenium plaque there. So this is now the radioactive ruthenium plaque, which is now being secured with the pre-placed sutures. That's how we anchor, and we have to make sure that it is nicely anchored to the sclera because it is going to stay in situ for some time. And by doing a preoperative dosimetry, we know exactly for how long we want this radioactive plaque to be in place. Here, if you remember, because we had disinserted the lateral rectus, so we are going to use this hangback technique to place the lateral rectus inside, and then ultimately when we are going to remove the plaque, that's when we are going to put the lateral rectus back into position. So this is the lateral rectus being temporarily reattached and using the hangback technique. And then this is the peritomy. Now the plaque is in situ, so now this is the conjunctival sutures using 8-0 vicryl that we use to suture this. And once this procedure is done, the patient remains in isolation because he's having a radioactive plaque. So depending upon how long we need the plaque to stay in place, the patient is in the isolation room. And after that, then we do the next procedure of plaque removal. So here, of course, we're just completing the peritomy steps, and then followed by a subconjunctival injection. And this more or less completes the video of placing the plaque, the radioactive plaque, and here a few seconds on how the plaque is removed. So here you can see that the sutures that we place at the time of peritomy, they are being cut, the plaque is being exposed. This is the ethibond suture that is being cut over here. We have to be careful not to cut the sutures anchoring the muscle because we have to reposition it back, the lateral rectus. So here you can see it is being tied back to its original position after the plaque has been removed. So we have these plaques coming in different sizes. We also have a notch plaque for tumors that are near the optic nerve because depending upon the location and the size of the tumor, we do our plaque selection. So this is again closing the peritomy after the plaque removal, and then followed by a subconjunctival injection. So cleaning up, maintaining sepsis, and acknowledge the whole team that is always behind us in doing this procedure, including our colleagues from radiation oncology and radiation physics and our anesthetist, and of course our own team of consultants and SRs. Thank you.
Thank you, Dr. Bhavna, for those wonderful videos. So after how many days you remove the plaque, and what all precautions you ask the patient to take during this period, when the plaque is...
While the plaque is in situ, the patient is indoor with us. He's not discharged until we remove the plaque. So he's in an isolated vary from a few hours to a few days, like depending upon the size of the tumor, the type of the tumor, like retinoblastoma, choroidal melanoma, OSSN. So we have a software, and it is the medical physicist. They calculate for us. We just give them the tumor dimensions and tell them what kind of tumor it is. And then based on, the dose that they want, the intended dose to the apex of the tumor, they calculate the duration for which the plaque has to remain in situ.
Any complication, common complication, or any issues with the patient
So
while they are?
basically the normal local radiation related complications like cataracts, or after a period of time they can develop, or they can also develop radiation induced optic neuropathy, papillopathy. So some of them, like if the tumor is at the posterior pole, we have to explain the prognosis that this is basically being done for tumor control, and vision may be compromised.
Okay, thank you so much. Thank you. Now I would like to invite Dr. Lomi. He'll be showing video on enucleation in ocular tumors.
So very good morning to you all. So shortly, I will show some videos of enucleation of this myoconjunctival technique. Now, enucleation is basically done for these ocular tumors, which are very advanced and not able to salvage by, like ma'am have shown that, like plaque brachytherapy, or especially is used in for choroidal melanoma, advanced choroidal melanoma, or advanced intraocular retinal blastoma. So the goal of the enucleation in ocular tumors is to remove complete removal of their tumors, and to give a better cosmosis, and also to get a good motility, less painful, and also to avoid any implant-related complications. So indication for retinoblastoma is unilateral group E retinoblastoma, or chemoreduction extraocular retinoblastoma, or if it is recalcitrant and have this nil visual prognosis. The points to be noted when you are doing enucleation in retinoblastoma is that you should have a very minimal manipulation and avoiding perforation of the globe, and as far as possible to harvest a long optic nerve stem, and to also inspect the enucleated eye for macroscopic extraocular extension and any optic nerve involvement, and avoid biointegrated implant if post-operative radiotherapy is indicated. So here's a video of this case of advanced retinoblastoma. So it's a group E retinoblastoma. So we are going for primary enucleation in this case. A 360-degree peritomy is done here, and that conjunctiva is separated from the underlying tenons by using a blunt tenon forceps, scissors, sorry, and due to a relaxation cut is given on the conjunctiva. First, you have to see and identify the muscles of rectus muscles. There is a middle rectus muscles. This is identify hook, and then it is sutured with a 6-0 vicro suture, and then it is resected, and then this 6-0 vicro suture has been attached to the conjunctiva. Here, people also use this this double arm vicro suture also, but however, in my techniques and all, I use this single suture only. Similarly, in all these 4 rectus muscle, this has been identified and hooked, and then in its place in the around this the appropriate dislocation around 5 to 6 millimeter away from this limbus. So out here, while you are cutting with this cautery, you have to be very careful here. Inadvertently, if it touch that's any part of the sclera, it will by any small touch also it will just perforate it, because this insertion of muscle site, the sclera just beneath the insertion muscle site is the thinnest part. So you have to be very careful. That's why I always use here to support. One support is given behind it to prevent its adverent touch. And also the assistant, while holding this muzzle hook, also should be careful. Not should be very taut enough so that suddenly that would be release of this tension, then it will touch the sclera. Here, sorry. Here again, I'm using this artery forceps to clamp this the base of this the muscles, the two lateral rectus muscles, and this I'm doing this pull up and cut down technique, so that instead of using this the enucleation scoop spoon, I'm using this two artery forceps, because in this you have got a very small space to enter the scissors here. So this is a silicone implant. Here you identify the posterior tenons again, and then once you identify the middle part of posterior tenon, you can know the plane, and then you can subsequently stitch with the interrupter suture using a 6-0 vicryl. And after that, subsequently you do the close the anterior tenons again. And then you close the conjunctiva with interrupter suture. Sometimes you can use this continuous suture also. Here I prefer to inject bupivacaine again post-operatively also, so that subtenons tenon, if there can maybe pain-free, less painful in case of in the immediate post-operative times. And then this temporary tarsorrhaphy has been given at least for 3 to 4 weeks time, that to secure that the conformer is well placed, and then there's no adhesions in the fornix again. Next video is a enucleation in the RB with the ophthalmos eye. So here we find a difficulty in prolapsing the globe here. So you need to do a lateral canthotomy here. So careful here again that you don't touch the other the globe again. The lateral canthotomy is done, and then you can see the globe can be very easily prolapsed here, and subsequently you can insert this enucleation scissor, and then you can feel and tuck this the optic nerve, and then you can trim it off. At the same time, you are pulling it up, and then your scissor is going down. So like you can try to harvest as long as the optic nerve stump again. And then after same procedure here, like after closing it in 3 layers, and then you're closing this the lateral canthotomy, which has been cut before. So this is the completion. This is after these completed videos. Like you have to insert a conformer again, and then the tarsorrhaphy, the lateral tarsorrhaphy has been not indicated in case of adult case, but especially in case of retinoblastoma, I prefer doing this temporary tarsorrhaphy. So these are the videos of post-operative the prosthesis after prosthesis. So I give courtesy to Mr. Sachin, this oculist also. And these are the pictures usually I used to show to the patient before while counseling also, because the parents and all they are like wanting the fear of the disfigurement of the eyes, and also this type of pictures we saw the very good pictures. They get mentally also prepared, and then we feel that they will go ahead for this whatever treatment is there in the patient. Thank you.
Thank you, Dr. Lomi. So would you like to give some important tips to the beginners, while dissecting intraoperatively, and about the size of the implant?
Yeah, while dissecting, as I have told, you have to be very careful again, like manipulation should be very minimal. And especially the most difficult challenging part, which I see the residents while going for the enucleation, is this while cutting the optic nerve stumps. So you have to be careful there, take time, and then your scissors will be appropriately in an appropriate position, and then try to harvest as long as the optic nerve stumps. But at the same time, you should avoid damaging other important structures. Sometimes that they go too behind, and then they start to damage the middle wall, fracture the middle wall also. So they have to be careful there. And then the assistance when going for the tamponade for this should be also be quick enough, and then would be like the adressor gauge piece has to be rolled in such a way that it will just tamponate in that orbital apex. Not that like if we push the conjunctiva down there and after coming out with this tamponate again, the bleeding will gush out again. So something that is like a blind process. So you have to be careful there again. And regarding the implant size, usually for the children, you check the axial length and then minus with 2 millimeters. In case of tumor cases, if the eye is statistical or bottomless eye, always compare with the other eye again, and then that's how we can measure it. And on table also we measure it and see that it's adequately closed. There's no fornixes, conjunctival tightening is there. So you have to look into all this account. Yeah.
And the other thing, do you always close the layers like horizontally, or you prefer closing horizontal and vertical direction?
Horizontal and vertical direction also can be done, but if you feel that that the conjunctiva, the tendons are like it's loose enough, and then it's not tightening, it's not there, you can consider for just horizontal also. But if it is like tightening, shortening is there, you expect, then you can consider for vertical and then also horizontal closing also. Yeah.
Yeah, okay, I completely agree. All right, okay, so thank you, Dr. Lomi, for that wonderful talk. Now, I would like to invite Dr. Neha. She'll be speaking on conjunctival tumor mass excision.
Good morning everyone. I'll be presenting this video of conjunctival mass excision in 34-year female with conjunctival mass extending from 7 o'clock hour to 12 o'clock lesion, and largest width was 6.4 mm. This is ASOST of the same patient. Surgery was done in peribulbar anesthesia. 4 mm tumor margin was marked with GB pen and till the limbus, and Vanna scissor was used to create a plane between the sclera and tenons. Then Vanna scissor was used to separate the tumor from the surrounding conjunctiva. Vanna scissor was further used to dissect the tumor from underlying sclera. Tumor was adherent near the limbus, so crescent blade was used to separate the tumor from this underlying sclera, and field was kept dry at all the times. Irrigating fluid was not used as it would lead to seeding of tumor in the surrounding areas. Then crescent knife was used to do partial sclerectomy at the limbus region, and tumor was separated using crescent from the surrounding cornea at the limbus. Then after completely removing the tumor from the ocular surface, alcohol will be applied to the cornea at the with 2 mm margin taken from the tumor, and then epithelectomy will be done. This is alcohol soaked cotton is applied over the cornea, and epithelectomy is done. Cryotherapy is done at the resected margins. Double freeze thaw technique is used to do the cryotherapy. Cryotherapy is done to eliminate the microscopic tumor cells at the margin, so that to prevent the recurrence of tumor. And after cryotherapy is completed, as the defect size is large, so AMG is used to cover the defect. AMG is placed over the globe, and it is cut according to the size of defect. AMG is cured with the help of fibrin glue, and sutures are applied. Fibrin glue is injected beneath the AMG to for opposition with the sclera. Then AMG margins are undermined beneath the conjunctiva, and then sutures 80 Vickel sutures are applied to oppose the AMG with conjunctiva. Ocular surface is then washed, and BCL is placed, and subconjunctival antibiotics and steroids are given. Thank you.
That was really short and sweet.
So any questions then we can take? I think Chief Sir will arrive any time. So, so I think we can just allow one speaker to speak from the next session, and Chief Sir will arrive by that time. So we have Now the session 2 is interesting cases in oculoplasty and oncology. So the first speaker is Dr. Parag, and he'll be discussing an interesting case of lacrimal sac tumor. Dr. Parag, please.
Yes. A very good morning again. I will be presenting an interesting case of lacrimal sac tumor. So, slight brief introduction about lacrimal sac tumors. They are extremely rare. They can be locally invasive and potentially life-threatening, and they are very commonly misdiagnosed as a case of chronic dacryocystitis, and therefore we need to look out for them. So, patient is a 21-year-old male student of Nehru Nagar, Uttar Pradesh. He presented to us with chief complaints of watering in the left eye for past 3 months and visible notable swelling near medial canthus for past 2 months, which was gradually increasing in size. There was no history of discharge or hemolacria, and it was not associated with any pain or redness. And there was no associated known systemic disease, no history of weight loss or fatigue.
Good morning, sir, and welcome, please.
Welcome, sir.
Sir, carry on with that.
Okay.
Okay, thank you, sir.
So there was no associated known systemic disease, and there was no history of weight loss or fatigue. So on ocular examination, it was normal, and I'm not going into detail of the ocular examination. On local examination, we were able to appreciate well circumscribed, firm, palpable mass below the left medial canthal tendon. The mass was found adherent to the underlying structures, and on syringing, there was reflux of fluid from the opposite puncta. On probing, we were able to appreciate a hard stop at 14 mm. Contrast enhanced CT scan was advised, and we were able to appreciate a hyperdense homogeneously enhancing mass lesion with expansion of the left nasolacrimal duct and slight bony remodeling, as we can see on the CT scan coronal section. And we were not able to appreciate any bone erosion. CT DCG was also done for the patient, and it showed filling defect, and it confirmed that the lesion was in fact present within the lacrimal sac. On basis of our clinical examination and imaging findings, we were able to reach a provisional diagnosis of a lacrimal sac tumor. We planned a dacrocystectomy, and it was done along with curettage of the nasolacrimal duct, and removed lacrimal sac in toto was sent for histopathological examination and immunohistochemistry examination. On histopathological examinations, it revealed a diffuse malignant round cell tumor with peripheral crush artifacts, and we were able to see lymphocytic infiltrate with multiple mitotic figures. On immunohistochemistry, we were able to see the stains were strongly positive for lymphoma, B-cell lymphoma, and negative for MPO and CD99. So histopathological diagnosis of a non-Hodgkin's B-cell type tumor was made. The resected margin of the tumor in fact came out to be infiltrated with tumor. Further, the PET CT whole body was done for the patient after removal of the tumor, and no metabolically active residual disease was found anywhere in the body. Patient was then referred to an oncologist for the need of adjuvant chemo or radiotherapy, and patient was advised a close follow-up and monitoring by the oncologist. Then patient was lost to follow-up and reported after 6 months to a different hospital with breathing difficulty, and their endoscopy revealed a nasopharyngeal mass of 2 centimeter. And again, biopsy was done for the nasopharyngeal mass by an ENT surgeon, which revealed a B-cell lymphoma. And repeat PET CT at that point of time revealed a metabolically active disease in the nasopharynx as well as in the D12 vertebrae. And currently, the patient is undergoing chemotherapy, which is the mostly followed and accepted therapy for the treatment of B-cell lymphoma. That is the CHOP-R regimen, which includes cyclophosphamide, doxorubicin, vincristine, and prednisolone, along with a combination of rituximab. Now, briefly about the lacrimal sac tumors. Histopathologically, they have been classified into epithelial and non-epithelial tumors. Benign epithelial tumors include papilloma, oncocytoma, adenoma, and cylindroma, and malignant ones include, most common one is the squamous cell carcinoma. Among the non-epithelial tumors, we have lymphoproliferative, melanocytic, and mesenchymal tumors. Among the lymphoproliferative tumors, lymphoma and leukemias are more common. So now, this was a meta-analysis review which was done by Krishna et al. In 2017. They actually reviewed the case series that were published from 1930 till date, and collectively they were able to come up with findings. So on basis of this study, only about 665 cases were reported of lacrimal sac tumors in literature from 1930s till date, and 55% of lacrimal sac tumors were malignant. And lacrimal sac tumors of lymphoid origin, only 85 cases were noted till date. Most of them were secondary in origin, and primary lacrimal sac lymphoma is extremely rare, as was the case in our case. And R-CHOP regimen is the preferred treatment for lymphoma, which the patient is undergoing. Now, point what we could have done differently for the patient was, we could have since the number of cases that have presented till date in literature are very less. There is no standard protocol that is to be followed. There are no standard guidelines, and role of adjuvant chemoradiotherapy is to be explored in such cases with after excision. Thank you.
Thank you, Dr. Parag. Now I would like to invite Dr. Bajaj, who is a unit in charge of oculoplasty and oncology services, to welcome Chief Sir and say a few words. Please, sir.
Thank you, Professor Neelam. First, I would like to welcome Professor Tityal, and we are honored that he has found time to come here and give us his advice. And also a very warm welcome to all the delegates and people who have come especially physically for this. And of course, there are a lot of people who have joined virtually also. But the people who are here physically, they will gain the most, because a one-on-one interaction with everybody and discussing the thing live is not the same as joining virtually. So welcome to all of you, and I hope you have a good time. And especially Dr. Swati Devanali, head of RIO Ahmedabad. We are honored to have such a senior person. She's a director at RIO Ahmedabad. So and I'm thankful to Professor Tityal for galvanizing the academic program. And even during the pandemic, we were doing the virtual workshops, but fortunately now we have come back to a physical mode, and it's a real blessing from God that we could come back. So, and he has also created a very harmonious environment in the center where everybody is working willingly and not because of it's their job. So that is the main thing, that he has changed the environment. So we really appreciate that, and we are thankful for that. So now I would like to invite Professor Tityal to the dais for his kind words. A little memento from us.
Good morning. Good morning to all of you. I think, you can say, I was just thinking, what has changed in last few years in the academic institution or academic programs across the country. All Saturday, Sunday have become a busy day for everybody. In all days, this used to be a free time, like you actually had a weekends. Now it is the most, I think, busy days for most people. Unlike some of our young people who like to be in their comfortable zone, and unfortunately, as Dr. Bajaj was talking about, COVID had its impact onto everything. That includes the area of teaching also. But it has given very, very positive things also and very negative things also, like online teaching and access to have all those webinars at your pleasure time. That gives you, sort of a laxity in your thinking that you should be there physically. As Dr. Bajaj nicely pointed out, physical interaction is totally different. You may not gain sometimes from the the printouts or the PowerPoint you see, but the physical appearance of person, his body language or her body language tells so many things to attract somebody's attention at that particular point. I think that I consider the teaching across the people sitting in one particular area. You all know RP Center is been the torchbearer in terms of academic program for this country, and we are very proud that we have done justice to this particular institution for the purpose it was established by the government. And RP Center being alone in the sea of academic program happening across the world, and so many aims has come up, but RP Center still stands the towering figure in all academic institutions. I hope that other aims, other institutions of government organization will have in future similar institution in their places. We have many RIOs. They have been upgraded. They are doing a wonderful work also. I hope they also come up to the similar way so that we have a better academic facilities, environment in these parts of our country also. The recent establishment of RIOs, a place like Patna, place like Banaras, where the two recent RIO has come up, and their concept have been like RP Center-like institution. And I've been part of their, you can say, a basic structure formation. I hope that I'll be again a part of their institution of actual placement of various activities which we do in a center like this. And that is what is needed in our future also. You all know the burden of blindness in our country is going to increase many, many folds in all aspects. Today we are discussing oculoplasty and oncology. This is going to be one of the major branch in future, especially the oncology part is going to be a bigger segment in our future for younger generation. Oculoplasty, the way we used to learn and teach has changed so much. So many things has come up which has right from the treating the defects, improving the cosmesis. So many things has come up, and that is, I think, going to a future also. I was just listening to the talk on Botox. I've learned so many points in that because that's a new thing for us. We never practiced in our life earlier. But the way Sahil taught us, the beautiful small points, how to make Botox, how to preserve them, how to inject them. These are small things you'll like to have, access to those things. Maybe there should be maybe we can organize some sort of practical tips for people also. We can have online demonstration happening. And the purpose of workshop in RP Center has been threefolds. One is having a social gathering like this where you have interaction. Second is giving them some sort of a live visualization of a procedures, which may be a live surgical transmission or a near live demonstration from video teaching also. Because I consider near live video teaching is much better, much more informative than the actual live surgery. because here you can stop anywhere, you can see the step again and again and discuss those points. So I think near live surgery is a better way to transmit the teaching to other people also. So this video assisted teaching is one of the good way to think of. Third important thing is some sort of wet lab training. That is also very important part, and we have been doing that for almost every workshop, some sort of demonstration, wet lab training. So that enhances your skill also. So these 3-4 folds we have been doing for every workshop. And this workshop is, special for me also, because being an anti-segment surgeon, I did have a little access to ophthalmoplasty during my, SR shift, because I had Dr. Ghosh in our unit. So I had to do a little bit of a syringing probing for hundreds of kids with so much of meticulousness, and my thesis was also in a pediatric ophthalmology at that time. I did some congenital fistula surgeries and some congenital lid repairs also. So I do have a little bit of soft corner for ophthalmoplasty, which I could never do it. But getting back to cornea also, we do have a lot of plasty in cornea also. But there also, as you get senior, then you start leaving those difficult areas, leave it to a younger generation. And I think the unit combination we had since my beginning days, we had a combination of ophthalmoplasty and cornea together. So we worked together for many years and still working on, despite having a multiple divisions of various segments in the RP center. The unit structure we have made in such a manner where each super specialty or a subspecialty is divided into our various units. The residents have access to these areas in every rotation. You leave anything like suppose anterior segment, you have access 3 times. So you have 1.5 months rotation, you are rotating at least more than 5 to 6 months in those areas. If you are doing going through retina, you have 2 units doing retina, so you still have 6 months of rotation, 3 months, or internal rotation can also happen in these cases. So this is one way of enhancing your exposure to various areas. We definitely accept people coming for short-term trainings from various institutions, normally from the government institution, but now it is open for private institutions also. And if you have a larger exposure, like people also come from a army background, they come for 2 years. So actually, those are the people who become actual expert in these areas. And we also have people coming for observership also. So it's open for everybody to come to RP Center and see what is happening, how they can improve their facilities in their areas also. So I would sincerely request all of you, especially those 15-20 people who have come from other places. I can see senior people sitting here also. They should contribute to all this teaching which is going here, and people who want to go through various areas must go there and approach our faculty members for their clarity in their work as such. Again, I would like to welcome all of you on behalf of faculty of RP Center, the staff, students. In fact, from the entire family of RP Center, you are all welcome to this center, not for it today, anytime in the future also, and hope that will make you comfortable in all respects. Wish you all the best for today's workshop. Hope that you learn something and give something back to us also. Thank you again.
Thank you so much, sir, for your encouraging and inspiring words and your advice and blessings. And moving on to the next session, but before that, we'll like to have a short break of 10 to 15 minutes. So, before that, we'll go. Yeah. Thank you.
अब ठीक है.
It's good ना सर आ गए ना. He's like better. अच्छा हुआ इंटरनेट डाउन है, नहीं तो हमेशा वर्चुअली होता है. इस बार फिजिकल हो गया. नहीं पर मुझे नहीं पता था ये ऑनलाइन हो जाएगा.
यही लैपटॉप है, यही होगा ना?
यही है। इसमें कहाँ था? अपलोड कर दिया। वो मेरा नाम लिख दिया।
मैंने नहीं किया,
मेरा तो डेस्कटॉप पे था।
मेरा भी डेस्कटॉप पे डाला मैंने, इस पे डालना है।
यही किसने किया? सेशन 2 में तो मेरा है ही नहीं। अभी जो चल रहे थे मैंने डाला है। ओके, मैं तो
किसमें डाला आपने?
मैंने अभी तो डाला। मैंने अभी तो डाला, कहाँ गया वो? अरे अभी डाला मैंने।
रीसेंट खोल दो।
सेशन बी, ये भी खोल। सेशन बी, सेशन बी का है। खोलिए आपके फोल्डर। अभी डाला मैंने सेशन 1, सेशन 2। हाँ ये तो ना तुम्हारा। नहीं, ये तो कल जो मैम के पास है ना वो है, वो नहीं। दोबारा डालना पड़ेगा।
ये इन्होंने किसका है?
ये इधर का, ये हमारा लैपटॉप। अभी डाला मैंने। कोई से डेस्कटॉप पे डाल दीजिए जो आपको चला। मेरा तो उधर ही अपलोड किया था। हाँ तो आप ओपन तो हो रहा था। इसमें आपका डालने में बता दें। ऐसे क्यों आ रहा है? ये किसी ने नाम क्यों चेंज किया? वो नाम डाल दिए ना वहाँ पे, रीनेम कर दिया उधर, तो तभी पता पड़ेगा ना सर, इसलिए डाला हुआ। अपना कौन सा इसमें कॉपी कर लो। ये वेरी नाइस। नाम बस लिख दो। नेक्स्ट सर नेक्स्ट नाम तो लिखे नहीं उसमें। क्या नाम है? चल रहा हो गया। हाँ एक सेकंड, मैं भी कर लेता हूँ। तुम्हारा कैसे नहीं है? मेरा भी चल रहा है।
Dr. Minali is here. Dr. Minali.
रिजेक्ट किया मनु का चला के। ये क्या? ये क्या है?
You can upload them.
तुम्हारा कहाँ है? देखो ओ सर मिल गया कहीं इधर सर्च कर। कौन सा टू में था?
So, Dr. Minali, are you ready with your presentation?
चलो वहीं डाल।
So, welcome back. We'll start with continue with the second session. That's an interesting case in oculoplasty and oncology. So, now I invite Dr. Minalni. She will be presenting an interesting case of periorbital mass.
Thank you, sir. So let's go directly into the case. So ये next नहीं जा रहे हैं? Okay. So, a 15-year-old boy coming from Haryana came to us with the chief complaints of a swelling on the left lateral side of the left eye. So, history of presenting illness was that he had a trauma, which was significant trauma with a cricket ball about 6 years back, after which he developed an acute swelling on the same site, which subsided after a few days, but the pain persisted. And after a few months, patient developed a slow growing mass lesion in the left temporal area and extending into the left periorbital area, which was gradual in onset, insidious in onset, and gradually progressive, but was associated with persistent pain. Coming to the negative history, he did not have any history of fever or evening rise in temperature, sweating episodes, any contact with TB. This is to rule out tuberculosis, because the location of the mass can, and sometimes the orbital TB can present like this. Then there was no history of recurrent redness or morning increase in the swelling. This is to rule out any inflammatory etiology. The patient did not have any history of weight loss or poor appetite or history of nodules elsewhere in the body. Now we are trying to rule out, with weight loss and poor appetite, any neoplastic growth, any malignant growth. And nodules, we're trying to rule out any neurofibromatosis, any plexiform neurofibroma, or he has neurofibromas elsewhere. He did not give any history of increase in the size of the swelling on bending down or straining to rule out varices. So on examination, on inspection, we can see that there is an ill-defined swelling on the lateral periorbital area, which is extending to the temporal area just short of the root of zygoma, and it appears ill-defined, and there are no overlying skin changes. On palpation, we found that it was a tender, well-defined mass, which was firm to hard in consistency. It was lobulated, it was tender, it was non-pulsatile, and which was present, and the bony margins of the orbit could be freely palpated. So it was completely outside of the orbit, and it was around 4.5 to 5 centimeter in dimensions, and the overlying skin was freely mobile, and the mass was also mobile, not adherent to the underlying bone. So on the clinical examination, we came to the following differentials. Dermoid, obviously, because the age of the patient, the long history, and the location points towards an external angular dermoid cyst. The second differential we kept was a benign mesenchymal tumor, because it could be a long standing duration. They are very insidious in onset, and the firm to mass mobile tissue, which is not adherent to the underlying bone. The third differential, which came lower down the list, was again orbital TB, but we could not feel that it was adherent to the bone underneath. So on imaging, on contrast enhanced CT, what we see is a very well defined encapsulated mass, which is homogeneous, solid, mild contrast uptake, and there are no bony changes seen. There are no bony changes seen or any postseptal extension of the mass. And also, what I'd like to point out here is, look at the shape of the lesion. It's fusiform, right? On MRI, T1 weighted MRI, we see a mass which is iso-intense to the muscle, again very well defined in the soft tissue, and on T2 it is hypointense. So our clinico-radiological diagnosis at that point was a benign mesenchymal tumor. So we went ahead with the surgery because we wanted to avoid the large scar it might create here. We went with the coronal approach, and thanks to the faculty in OMFS, Dr. Rahul, who came and assisted us with the procedure. I'll be showing the procedure, but before that we should understand some anatomy. That coronal incision begins 4 to 5 centimeter behind the hairline. You have to prepare the area beforehand, then you extend it temporally and bring it in the preauricular area. Now, important is the plane of dissection. So, scalp has 5 layers: the skin, the subcutaneous layer, the musculo-aponeurotic layer, which is formed by the frontalis and the occipitalis, and below that, you have the subgaleal fascia. This is the plane where you operate. This is for its ease of dissection. It's very, you can bluntly dissect just with your fingers, and when degloving injuries happen in the scalp, this is where degloving happens. And the importance of the incision is that you have to keep the incision just in the preauricular area, because facial nerve branches come out over here, and they are about 0.8 to 3 centimeter, 5 centimeter ahead of it. So going back to the surgery, let's look at the video. Okay, so we made the incision, which is around 4 to 5 centimeter behind the hairline, and we are extending it temporally. We are in the subgaleal plane, and we are dissecting it bluntly. Wherever there is ooze, you can put Rainey's clip. See, just blunt dissection. With the back end of a knife, you can dissect, or with your fingers, you can dissect. Then extending it temporally, and your incision will end just in the preauricular area, just anterior to the ear. Right now, what we are going to, after you've bluntly dissected your scalp area here, when you come to the temporal area, you have to further dissect the subgaleal fascia. The white glistening layer that you're seeing is the superficial temporalis fascia. You have to do a 45-degree dissection here. Make sure that the temporalis muscle which comes here is not injured, because it will bleed a lot. Now we are exposing the root of the zygoma, the temporalis muscle, and now we are going to make the subperiosteal incision, which is 3 to 4 centimeter above the superior orbital rim. So we are raising the periosteum, and here you can see this bulge, the mass has come. So we have reached the plane of the mass here. This is the periosteum being elevated. And this is the mass. So now further dissecting the mass, we are dissecting the mass from the musculo-aponeurotic layer here, superficially. You can see it's a well encapsulated lesion. And inferiorly, we are just continuing the dissection in the subperiosteal plane. We are dissecting it further in the subperiosteal plane and elevating it. Now, what is important is you look here, the structure. There's a foramen and there is a nerve coming out. So we can see that the mass is arising from a nerve, and the foramina here gives rise to the zygomaticotemporal nerve. So this probably is a tumor which is arising from the nerve or the nerve sheath. And looking at the fusiform shape, we can say that it might be a schwannoma, which we'll confirm on histopath. Further dissecting it. So we've taken out the mass, and then we've closed the scalp suture in 2 layers with forovicryl and forosilk. Okay, so this is the gross specimen. This is the lobulated, the rubbery, and you can see that sigmoid shape or the fusiform shape of the mass can be appreciated here. So on histopathology, it was a cellular schwannoma. There were more this is courtesy to Dr. Seema Kashyap. And we can see that there is more of cellular schwannoma, more of the Antony A areas and not Antony B. You can see the palisading of the nuclei here and here and here. And S100 was positive. So we made a definitive diagnosis of schwannoma, a cellular type histopathologically, of the left zygomaticotemporal nerve, a sensory nerve. So this is the post-op day 1. We took the coronal approach because we wanted to hide the scar, and this is post-op 1 month. The scar is not at all visible. So now this poses a question: was like the trauma in this case just an incidental thing that history just unmasked the tumor which was already present, or does trauma play an etiology in this tumor? So we did a thorough literature search, and we found that there are case reports reported in literature which tell that yes, trauma can be an inciting factor, and there are post-traumatic schwannomas reported. So this one is a 68-year-old female with a laryngeal schwannoma after she underwent thyroidectomy, and she had persistent hoarseness. This is another case which is in a footballer who was 29-year-old, and he had trauma, and after 1 year of that he had consistent swelling, persistent swelling for 1 year, which came out to be a schwannoma. Then this is of 4 years after road traffic accident. 21-year-old presented, like where the fracture was at the same site, he presented with a schwannoma after a year. This is the another case report in which we found, in which they've described that the 28-year-old male who had concussion, he had a sport-related concussion, and he developed a schwannoma in the same C2 cervical spinal nerve. So, although majority of schwannomas are idiopathic, some have suggested that trauma may play a role in their development, and the proposed etiology that they've given is that the injury can trigger a neoplastic transformation of tissue, prompting a schwannoma formation. So the take-home message here is that in any patient who comes to you with a significant trauma and followed by development of a mass lesion in that area, so you should keep a differential of schwannoma high up in your list. Thank you.
Thank you, Dr. Mrinali. That was a very interesting case. And I want to ask one thing. Other than this coronal approach, what are the other approach which can be done in this case? Because being an ocular surgeon, it is become very like a gross surgery for us. Like if it is like for plastic surgery, obviously this is a simple case for them. But for the ocular plastic surgeon or the ocular surgeon, what
So
you
we
would
can
suggest?
take the direct skin approach, but that would leave a scar.
Okay, that's for
Or
cosmetic
we can,
reason
yes,
only.
sir, and we can extend the lid crease insertion, the lazy.
Okay, so in this case, like post-operative is how was the post-operative looks?
So post-operative is, he doesn't have a scar right now.
Initially, like there would be lots of chemo. Otherwise,
He
could
has lots of sensations because the tumor was arising from a sensory nerve, but this is pre-op of the patient, and post-op he completely doesn't have any scar here.
okay, and this case is done under general anesthesia.
Yes, sir.
If it is any other approach, you can consider for local anesthesia also.
So all orbitotomies we do under general anesthesias.
But is this like
This is periorbital.
Periorbital side. Yeah.
Could have been done under.
Okay, very. Yes, yes. Okay, very interesting. Thank you. So moving on to the next speaker, we have Dr. Bhupender. He will be speaking on some uncommon eyelid disease. Dr. Bhupender.
Thank you, sir. I'm going to present the uncommon eyelid disease called amyloidosis. It is a rare disease. Here we can present the few cases. In first case, there is a 27-year-old male who had a painless, gradually progressive swelling of the right upper lid from last 5 years. On examination, soft, non-tender, diffuse swelling with mild ptosis and inferior dystrophy of the right globe was present. Patient is in follow-up for last 5 months, and complete systemic examination was within normal limits. This is the MRI of this patient. Here we can see a diffuse soft tissue lesion in the right upper lid, which is hyperintense to isointense in T1 and T2. There was an intraorbital excision involved with the anterior part of the LPS, superior rectus vessel, and the lateral rectus vessel. The right lacrimal gland was also involved by the lesion. This is the contrast NS MRI of the patient, which show the diffuse enhancement of the space occupying lesion. This is a case second. This is a 39-year-old female who had a painless, gradually progressive redness of the left eye for the last 3 years. There is history of recurrent subconjunctival hemorrhage was present. On examination, patient had a mild ptosis in the left eye and flashy pink lesion involving the upper and lower fornix in the left eye, and on only the lower fornix in the right eye, with engorgement of the conjunctive vessel present in both eyes. Patient is in follow-up for last 8 years with no progression seen. ERD systemic workup was within normal limits. Here's the third case. This is a 39-year-old male who had a painless, gradually progressive swelling of the right lower lid for last 8 years. On examination, there is a nodular swelling present in the right lower lid with madrosis. Complete system examination within normal limits, and the patient is followed for last 3 years with no progression seen. ELE system workup was within normal limits. Here's the fourth case. This is a 30-year-old female male patient who had a painless progressive swelling of the right lower lid for last 18 months and had a hoarseness of voice for last 3 months. On examination, there is a lower lid swelling was present with entropion, and the lower palpebral conjunctiva diffuse irregular thickening with patchy loss of normal conjunctiva was noted. ENT evaluation revealed a nodule in the larynx. Entropion correction with conjunctival excision with mucous membrane graft was and everting surgery was done. Patient is in follow-up for last 2 years with no progress seen. Yearly systemic workup was within normal limits. Now we have 4 patients with different presentation, and we did the biopsy for the patients, and we found out that there is a eosinophil deposit in the space and subepithelial space in the HND state, and there is a bifidobacterium under the polarized microscope in the congruent distant. So the diagnosis of amyloidosis was made. And after the diagnosis of amyloidosis was made, systemic workup was done to rule out the systemic involvement. It includes the complete physical examination, complete blood count, cognitive tests like BT, CT, PTNR, and renal hepatic function, 24 hours urine protein test, and blood and urine immunoelectrophoresis to rule out the presence of M-band. And it includes the autoimmune lab testing and electrocardiogram and echocardiogram. Chest, abdomen, and abdominal fat biopsy are the optional. Now we discuss little bit about the amyloidosis. The word amyloid was introduced by the Rudolf Virchow in 1854. Amyloidosis is a condition associated with a number of inherited and inflammatory disorders in which extracellular deposits of fibrillar proteins are responsible for the tissue damage and functional compromise. These abnormal fibrils are produced by the aggregation of misfolded proteins. The fibrillar deposit bind a variety of proteoglycans and glycosaminoglycans, which include the heparin sulfate and dimethyl sulfate, and the plasma protein, notably serum amyloid P. The pathogenesis of amyloidosis result from the abnormal folding of protein, which become insoluble, aggregate, and deposit as a fibrous in the extracellular tissue. Normally, misfolded proteins are degraded intracellularly in proteasomes and extracellularly by macrophages. It appears that in amyloidosis, this quality control mechanism fail, leading to accumulation of the misfolded protein outside the cells. In this figure, we can see the mechanism of the pathogenesis, how the amyloid deposit occur. In case of AL protein and AF protein, there is a production of abnormal amount of protein, which is normal, which is structurally normal. But in case of ATTR amyloid, there is a production of normal amount of mutant protein, which accumulate in the cells and cause the amyloid. We can classify the amyloidosis in a localized form, which include the only single organ, such as the eyes or heart, or we can divide, or we have a systemic generalized form, which include the several organ system. Systemic form is further divided into primary amyloidosis and secondary amyloidosis. Primary amyloidosis is associated with clonal plasma cell proliferation, and the secondary amyloidosis occur as a complication of underlying chronic inflammatory process like rheumatoid arthritis. There is another form which is hereditary of family amyloidosis, which constitute a separate, albeit heterogeneous group with several distinctive patterns of organ involvement. In this table, we can see there is a which protein are mainly involved in the systemic form. In systemic form, the major protein involved are AL, A or A2B, and which cause the disease like multiple myeloma, chronic lymphatic disease, and chronic renal failure. Treatment depend on whether disease is ocular or systemic. In ocular disease, the management modalities include the observation, surgical debugging of the orbital or eyelid mass, or mass excision. Radiotherapy and cryotherapy have been tried. Radiotherapy is used usually in case of significant orbital involvement with proptosis or extraocular muscle restriction. Radiotherapy causes the ablation of the monoclonal proliferation of the plasma cells, which produce the antibody that are precursors of amyloid. Cryotherapy causes the disrupting of the blood supply and killing the lymphocyte plasma for the deposit in the abnormal proteins. In the systemic treatment, we aim the treatment according to which type of amyloid we encountered. In case of the amyloid, the aim of treatment is to suppress the acute phase of response, which includes the immunosuppression like clonazepam, and in case of family medical fever, we use the colchicine. In case of AL amyloid, the main aim of treatment is suppress the production of monoglobulin immunoglobulin light chain. In case of hereditary amyloidosis, the main aim is eliminate source of genetic variation, which include the liver transplantation. In case of hemodialysis amyloidosis, the main aim is to reduce the plasma concentration of beta-2 microglobulin, which include the renal transplantation. Review literature, we search the sub literature search, and we found that there is a few good studies about the ocular amyloid. In this in the case series, this is a retrospective non-comparative case series. There are 41 patients are included, in which 29 patients are females. The mean interval from the presentation diagnosis is around 24 months, and the common presentation are the conjunctival mass and the ptosis. And three-quarters of the patient in this series have the localized primary and primary ocular adnexation or orbital amyloidosis, and the 4 patients or around 10% of the total patient have the associated systemic disease, and the 50% are found to underlying hepatitis malignancy. And this is a few pictures we take from this study. Here we can see the recurrent mass of amyloidosis. We initially diagnosed as the pyogenic granuloma, and this is the amyloid which affect the multiple structure, including the right transectiva and the bilateral upper and lower layers. In the lower down picture, here we can see the thickening of the eyelid, which initially diagnosed as the recurrent case of Calazion. This is another study published. This is a retrospective non-comparative intervention case series. It includes 24 patients with a mean age of 57 years. The clinical signs include the visible and palpable periocular mass, ptosis, periocular discomfort or pain, proptosis and glow displacement in 21%, limitation in ocular motility, and recurrent periocular subcutaneous hemorrhage and diplopia. 7 cases had an orbital involvement and 17 has a periocular involvement, and treated modality are mainly the observation and surgical debulking. These are few pictures we take from this paper. There is a 53-year-old male who presents with recurrent periocular subcutaneous hemorrhage, and another there is a bilateral temporal supratemporal non-tender mass present in the area of lacrimal gland and ptosis. Patient is known case of systemic amyloid light chain amyloidosis. Low down in the picture, there is an 85-year-old male who presents with severe ptosis and recurrent subcutaneous hemorrhage. Take a long-standing, painless, non-tender lesion that can be associated with recurrent subcutaneous hemorrhage could be amyloidosis. Systemic workup is necessary in case of localized to rule out the systemic involvement and keep the patient in the regular follow-up. Thank you.
Okay, thank you, Bhupinder, for such a good synopsis on amyloidosis. So I just want to ask you one thing. From the histopath picture alone, can you infer the etiology, whether it's primary, secondary, or what type is it?
No, sir.
You can't?
No, sir.
Because
we can only diagnose that there is amyloidosis or present or not. We can diagnose this primary or we can rule out with systemic examination.
From histopathology alone, you're not able to make out the etiology, right?
No,
it presents as a similar picture in all the groups. Dr. Praveen Mongre wanted to ask a question. Yes, please.
Yes, sir. No, sir. It's depend on the any medicine people, na. No, sir. We look for the M band presence or not. In all cases, there is no presence.
In your case, you had shown that M band was present.
No, to look for there is a presence of M band or not.
Okay, so but what I'm simply asking, in the gamma globulopathies,
yes,
this amyloidosis on one end and multiple myeloma is on the other spectrum.
Yes, sir.
So in your medical oncology, do they include everything, including the bone marrow biopsy, or not, or do they fall short?
Yes, sir. Yes, sir. Yes.
They do, no? That's what I'm
yes,
asking. That is what.
Yes.
So in your cases also they did.
Yes, sir.
Bone marrow biopsies
yes,
was
sir.
done.
Yes, sir.
And what was the findings there?
Sir, no non-consequence.
Okay, thank you.
Dr. Sen wants to add something to that.
I just wanted to add that we can do a subtyping on histopathology
Yes,
if we
sir,
have
in
the
on-
monoclonal antibodies.
Yes, on ICA of a mass spectrum.
If it is needed, it can be done, but as of now, we don't have these antibodies, AL and AA. They can be distinguished by IHC, immunohistochemistry.
Yes.
On histopath,
No,
further
primary or
testing,
secondary,
can we find
just
out
tell,
the
if we use
cause?
the antibodies, we can tell whether it's AL type or AA type. So
Okay.
that can give a lead, but we
and
can't
which
definitely.
will lead to some difference in the management?
Yeah, he's extensively reviewed that.
All right, so
AL is usually
very good.
localized.
So it's quite rare. We don't see these cases so often, and it's so sort of widespread in the body. It can, infiltrate any tissue. So sometimes it can mimic a lot of other diseases. So it's very important to, get the tissue diagnosis and
Yes.
then zero in on that. Okay, thank you
Thanks.
so much. The next speaker, who is that? Dr. Asmita? Dr. Asmita is there? Yeah, okay, carry on.
Okay. So I'll be presenting a case of a 23-year-old male who presented to our department with chief complaints of redness, watering, and nodular masses present in both eyes for the past 3 months. He was a known asthmatic on bronchodilators. Unfortunately, we did not have a preoperative picture. This is after one of the lesions was excised. So the patient basically had bilateral subconjunctival nodular masses. There was no evidence of any ulceration or necrosis. The rest of the conjunctiva seemed pretty normal. And as we can see, there is a large nodule present in the subconjunctival plane in the left eye. The size of this nodule was about 1.5 into 1.5 centimeters in size. So what was the history of this patient? The patient had been having histories of recurrent episodes of redness in both the eyes, which was being treated as conjunctivitis outside. However, there was no significant response, and he started developing nodular masses in both the eyes. He went to an ophthalmology institute where he was started on an oral anti-tubercular regimen on the clinical suspicion of tuberculosis. They performed the biopsy at the center, but the biopsy was negative for tuberculosis, so anti-tubercular drugs were stopped. Then they suspected that it was probably an autoimmune scleritis, and they started the patient on oral steroids. There was a reduction in the size of the swellings, but when they stopped the steroids, there was a recurrence in the swelling, and the patient then came to us. We took an extensive history to look for any other suspicion of autoimmune conditions. So we evaluated for any dysphonia, any hoarseness, any nasal deformities, any cranial nerve palsies, any shortness of breath, arthritis, parotid enlargement, any nodules in the body, any abdominal pain, any oliguria, hematuria, fatigue, any other systemic involvement, but there was none. We looked at the clinical picture. He had the eyelid and ocular adnexa was normal, but the conjunctiva showed 1.5 into 1.5 centimeter nodular fleshy vascular lesion arising from the sclera. There was no fundus involvement. There were no RL cells, or there was no evidence of any inflammation in the posterior uvea. So it was just a localized lesion which was present in the subconjunctival plane, probably arising from the sclera. So what were our differentials at this point of time? The most obvious seemed to us that it could be a tubercular lesion or any other granulomatous condition like sarcoidosis, Wegener's, or leprosy. It could still be autoimmune conditions. It could be fungal. It could be a collagenous tumor, or rarely it could even be a presentation of an IgG4 related disease. The investigations were done. His ESR was erased. The ANA and NCA came out to be, however, negative. The serum ACE and the 24-hour urinary calcium was also negative. The VDRL was also done, which was non-reactive. Incidentally, at this point of time, we noticed that there were some nodules present over the ear, which were noted to be arising from the cartilage, mainly in the upper two-third part of the ear. So we took a biopsy from these nodules, and this is what was the clinical picture we got. These nodules were showing that there was fibrosis and there was a polymorphous cell infiltrate. There was extensive destruction of the central cartilaginous part, and there was polymorphous cell infiltrate in this region. Then we went ahead with the histopathology of the scleral biopsy, and we saw that there was a polymorphous population of cells comprising of histiocytes, lymphocytes, and plasma cells. We did special stains for fungal organisms, and it came out to be negative, and also for acid-fast bacilli, which was also negative. So based on the presence of these recurrent auricular chondritis lesions which were presenting in this patient, which were incidentally noticed by us, along with scleritis and our histological features, we made a diagnosis of relapsing polychondritis. Now, what is relapsing polychondritis? It is an immune-mediated systemic disease. There is recurrent inflammatory episodes of the cartilaginous and the proteoglycan-rich tissues. The auricular chondritis, which is the most common manifestation, followed by polyarthritis. There can be painful inflammatory crisis, which can be followed by a spontaneous remission. Antibodies have been detected in some patients which are directed against the collagen 2, 9, and 11. There is a cartilage-specific autoimmunity thus present in patients of relapsing polychondritis. These are the most common manifestations that relapsing polychondritis patients present with. The most common organs involved are the ear and the hands and basically the joints. In ears, you can have painful red violaceous erythema and edema which is confined to the cartilaginous part of the ear. This is a point to be noted that since the lobule of the ear is devoid of cartilage, it is usually spared in these patients, which is a very characteristic clinching sign in these patients. The cartilage tissue will eventually be get replaced by fibrous connective tissue, which leads to a cauliflower ear-like appearance. Due to the extensive destruction of the outer hearing mechanism, the conducting hearing loss can also be present in these patients. The second common manifestation is an acute asymmetric intermittent polyarthritis. The point to be noted here is that it is a non-erosive polyarthritis. So these patients do not present with any particular deformities in their joints. It is just a recurrent inflammation in these joints. Which are the joints which are most commonly involved? That is why I've put a picture of the hand to re-emphasize. The metacarpophalangeal joint, the proximal interphalangeal joints, joints of the hands. In addition, the joints of the knees, and less commonly ankle and wrist can also be involved. In eye, the manifestations are very different from what we saw in our patient. Patients usually present with episcleritis or scleritis and conjunctivitis. It can cause peripheral ulcerative keratitis, uveitis, retinal vasculitis, ischemic optic neuropathy. These are the conditions which have been reported previously in patients, different from what we saw in our patient. This is what a cauliflower ear looks like. There is a swelling and erythema of the cartilaginous part of the ear, sparing the lobule which lacks cartilage. Eventually it leads to this kind of an appearance, the cauliflower ear appearance. There is fibrosis of the outer ear. The nose also is another organ which has cartilage, and there can be prominent saddle nose deformity due to destruction of the cartilage and replacement by fibrous tissue. This is an article which reported the ophthalmic manifestations. So patients have presented with uveitis, retinopathy, scleritis, and polychondritis, but scleritis, but patients have not generally presented with the kind of picture we had, that scleral nodules have not yet been reported in patients. Diagnostic criteria of relapsing polychondritis has undergone various classifications. The most common parts of the body which are involved are the auricular chondritis. It can have non-erosive polyarthritis, nasal chondritis, ocular inflammation, and in addition, I forgot to mention, respiratory tract can also be involved. The patients can have tracheomalacia, tracheal stenosis, subglottic stenosis can also be present. There can be audiovestibular damage. So any of these six may say, any three clinical features, if they are present, they are clinching diagnosis of relapsing polychondritis. However, if you don't have these all clinical criteria, you can confirm them with histologically. And Damiani and Levine have defined that if any one of the six clinical features are present, in addition to a histological confirmation, then also we can confirm relapsing polychondritis. Miket et al. Has also defined that confirmation of inflammation in any two of these three cartilages or proven inflammation in one of the above cartilages plus any other two minor criteria among hearing loss, ocular inflammation, vestibular dysfunction, or even a seronegative arthritis can help in diagnosis of relapsing polychondritis. This is what the histology of these patients looks like. The cartilage loses its basophilic quality because there is destruction of the cartilage, and it becomes more eosinophilic as the disease progresses. There is fragmentation of the cartilage with necrosis and lysis of the cartilaginous plates. In addition, we can see that there is infiltration of the cartilage with neutrophils and lymphocytes, and deposition of fibrin is noted in the soft tissues around the cartilage. Management of this patient, first of all, you have to look for any other systemic involvement in these patients. So in our patient, we referred the patient to rheumatology. He underwent systemic evaluation. Laryngoscopy was done for the patient. Cardiological evaluation was also done for this patient, because there can also be patients in which patients can develop valvular stenosis or aortic regurgitation, or even the aortic arc aneurysms can be seen in this patient. So for that also he was evaluated. He was evaluated by rheumatology for any involvement of any joints. After looking at the severity of the disease, how extensive the disease involvement is, that is when we decide our management plan. If just pain and inflammation episodes are occurring, we can just give NSAIDs and get away with it. If there are mild manifestations, you can give dapsone or colchicine. If, however, the patient is not responding to these treatments, or if there is a severe form that ocular, laryngotracheal, tracheal or cardiac involvement is present, then you can even consider systemic corticosteroids. However, patients can also present with life-threatening conditions, especially when patients present with tracheomalacia. In those conditions, in addition to IV steroids, you can also consider immunomodulator therapy like cyclophosphamide, azathioprine, etc. In addition, even plasmapheresis and IVIG has also been, plasmapheresis has also been described in these life-threatening conditions. So that is how we managed our patient. We started the patient on prednisolone and methotrexate and excised the nodular masses present over both the eyes. Postoperatively, this was the clinical picture. Subsequently, he was being managed under rheumatology department. The auricular redness has decreased. The ear nodules continue to persist. Currently, the patient has been taken off steroids and now is continuing treatment on Dapsone. Take-home message is that relapsing polychondritis can present in an enigmatic fashion and is often misdiagnosed. However, I would still like to emphasize that other more common conditions like infections, ANCA-positive vasculitis are more common and they present in a similar manner and must be excluded before coming to this diagnosis. And high suspicion of index is required in the absence of those classical scleritis, episcleritis and uveitis-like picture that normally patients present with in patients of relapsing polychondritis. Thank you.
So there are other presentations. I mean, this one was one. It can also present in the orbit as proptosis and sometimes the ocular motility problems, right? So it's such a, again, kind of a disease where a lot of multi-organ involvement can occur. So unless you have a, this one was, the biopsy was taken from?
The biopsy was taken from the ear nodule that helped us clinch the diagnosis.
Are there any other questions or comments?
At what stage the scleral nodules were removed? After giving systemic treatment and reducing it, or like the first sitting itself?
Ma'am, patient had already received steroid treatment outside. He was being treated at GNEC. He had already received steroid treatment. The nodules were not resolving. So when he came to us, we removed the nodules and put the patient on steroids.
Was there any like underlying scleral invasion?
No, there were not. Underlying sclera was normal. Yes, ma'am.
Very interesting case, Dr. Asmita. Well, I just want to know, with the name suggests it's a relapsing polychondritis. So how common is the chance of relapsing again?
So that is why patient need to be on long-term therapy. There are recurrent episodes.
Yeah.
There is an episode of inflammation and redness. It subsides, and after that it can develop another episode. So it does lead to relapses, and patient may need to be on long-term therapy. That is why the
and
patient
also
has
new
been put
lesion
on.
can occur in
Yes.
new site again.
That's why patient is currently on Dapsone to
Okay.
prevent the relapses in future.
Okay, thank you. So moving on to the next speaker, we have Dr. Abhijit. He will be speaking on a typical presentation of choroidal melanoma.
Morning, everyone. I'll be presenting a typical case of choroidal melanoma. So, a 13-year-old male boy presented to outpatient department with diminution of vision in the right eye for a couple of months. There was no history of trauma or no other significant history. On examination in right eye, he was PR inaccurate in 2 quadrants, and rest of the anterior segment examination was within normal limit, but in posterior segment examination, there was exudative retinal detachment and faintly pigmented mass was seen inferiorly in the vitreous cavity, and the media was hazy, so rest of the details could not be made out. Left eye was within normal limit. So an ultrasound was done. In ultrasound, a mushroom-shaped lesion with homogeneous moderate amplitude spikes filling nearly in the entire vitreous cavity with overlying retinal detachment was seen. So this is the ultrasound in 100 decibel gain. We can see that there is an overlying retinal detachment. It's a mushroom-shaped large mass, 16 into 13 mm, and it's a B by A scan. So there is first high amplitude spike followed by a classic decrescendo sign, and hence CE MRI was ordered, contrast enhanced MRI, and T1 showed brightly enhancing lesion, and T2 showed hyperintense mass overlying 2/3 of the globe reaching up to the posterior capsule of the lens, and a likely diagnosis of melanoma was made, and PET CT was done and it ruled out systemic metastasis. So our differentials, it was quite a classical presentation of choroidal melanoma. However, still we had few differentials like retinoblastoma, but there was lack of calcification. It was unilateral presentation, and age of presentation is not typical for retinoblastoma. any metastasis to the eye were ruled out with PET CT, and it was not likely to be melanoma because size of lesion was too large for it, and also it had low internal reflectivity unlike melanocytoma. So patient was diagnosed as right eye large choroidal melanoma with exudative RD, T4A, N0, M0, which classifies as stage 3A. He was planned for right eye enucleation under general anesthesia. Visual evoked response was done, and just to show that there was no significant response, and a written informed consent was obtained, and right eye was enucleated with insertion of 20 mm PMMA implant, and enucleated globe was sent to histopathology. And this is the intraoperative clinical picture with we can clearly see that there is retina behind the lens. And photo courtesy Professor Seema Singh. So this is H&E section of whole globe showing cornea, iris, and this is a melanotic mass. And on 20x magnification we can see spindle cells, which is confirms to histological grading G1. So why this case was atypical? The age of presentation was very young. The median age is around 6 decades, and it was advanced melanoma with diminution of vision reported only for a couple of months. Also, it is seen that in a young age, the melanomas are mainly related to iris, and posterior melanoma is less in younger age. So that makes it quite a typical presentation. At last follow-up over 6 weeks, the artificial eye has been placed and patient is doing well. So this is a study by Fry et al. Which looked at posterior uveal melanomas in adolescent and children. It was published in 2018. So overall incidence is reported to be around 4.3, and in most of the studies it's reported as around 4 to 5 per million population, and less than 1% of posterior uveal melanoma are in patient below 21 years of age, making it quite rare. And it is observed that posterior uveal melanoma manifests preferentially during or after puberty, and this was also seen in our case. At the age of 13, suddenly for a couple of months it progressed to such a large size, and there could be association of growth hormone with tumor growth. And this is a study by Singh et al., and they have given incidence per million population, so it can be seen that it's quite rare in this 10 to 14 age group. And many studies have concluded that pediatric and adult melanoma are similar in prognosis and clinical appearance, and treatment is essentially the same. And coming a little bit to genetics, so a recent study by Hare et al. Examined the chromosomal mutations in young patients with posterior uveal melanoma and found that majority of these tumors showed disomy 3, and it was correlated with good survival outcome, and monosomy 3 and 8q gain correspond to highest risk of tumor metastasis, and disomy 3 in fact correspond to lowest risk of metastasis. Hence, choroidal melanoma can present in young age, and high clinical suspicion is needed. Thank you.
Okay, thank you, Abhijit. Also, one thing I would like to add here, ma'am. Also, I want to ask ma'am also, like, how you would like to differentiate with a melanocytoma? Like, it is more commonly other than melanoma. It is age group also.
Melanocytoma, the histological picture is quite different. The cells are very large. They have got abundant cytoplasm, and they're very monomorphic in appearance. So they're very unlike, like melanomas are usually spindle or epithelioid cell with a lot of pleomorphism. So these are very benign looking cells, large cells with abundant melanin pigment and a centrally placed nucleus. So I remember a case we had, ocular melanocytoma, quite some time back, and that particular child had cutaneous melanocytosis also, multiple nevi all over his body. And it's not difficult to distinguish melanocytomas from melanomas because they're never spindle cell type, and there's no pleomorphism or mitosis like in epithelioid cell melanomas. Very benign looking tumors.
One question from Dr. Mongeser. Yeah.
One is like you said that the prognosis is same in adult and childhood melanomas. So one is there any difference in histopathology or ICG markings in adult type of melanoma or pediatric one? Second, since we all know that by the time melanoma clinically presents, it is assumed that it has already spread into the system. So what is your protocol to follow this child up for life?
So, sir, we are following these melanoma child every 3 monthly. We'll screen the other eye, and we do PET CT yearly to rule out any systemic metastasis.
How frequently, sir?
PET CT yearly, sir. Yearly PET CT, and also patient is instructed that if they feel sudden, if they feel any floaters or diminution of vision in the other eye, they can report earlier.
Yes, for yeah.
Yes.
You see, surveillance and follow-up will be very critical in this patient. He's, presented to us at a very early age, and there have been reports where there has been micrometastasis, even at the time of enucleation. So we don't have much data on how pediatric melanomas behave because, for the simple reason that they're so uncommon. But by and large, we would treat whatever the standard protocol for management for adult melanomas is. We would treat the patient the same way. So we usually keep the patient under close follow-up. They're already registered in the medical oncology or pediatric oncology clinic, where the child will be undergoing 6-monthly chest X-ray and liver function tests. Whole body PET CT is an expensive examination, so we reserve it only for annual checkups. But yes, other tests to rule out metastasis, including liver function test, chest X-ray, and ultrasound abdomen. These are things that we would like to do more frequently, say every 6 months in this child. And of course, clinically also, we would like to keep the child under close follow-up. We may also like to do a repeat MRI of the orbit. So again, pediatric age group, what does the literature say? I don't think that there is much on metastasis, but in adults, though, chemotherapy has been tried for patients with liver metastasis and immunotherapy and all these things are there, but the prognosis overall for metastatic melanoma is very poor. So despite trying different kinds of treatments, patients don't survive. And so I think the SEER data which you presented, Dr. Arun Singh's study, that is the entire, because we see much less melanoma patients than what is seen in the West. So in the US, they have the SEER data of the adult melanoma population, in which over a period of maybe 4 or 5 decades, they have analyzed the survival as well as the I really don't have the figures with me, but we can refer to that publication for more details. That publication is something you have mentioned in your this thing also, presentation. And incidence and survival of melanoma in the United States. And now there are more and more evidence that it is genetically linked. So if you have monosomy 3 or disomy 3, that is now genetic testing is now being routinely done as a prognostic indicator also, not just for diagnosis but for prognosis. So disomy 3 is supposed to have a better survival, and patients with monosomy 3 have a poorer prognosis as well. So they require more aggressive surveillance and more aggressive follow-ups. We have not done in this particular case. We offer to the patient. It is currently it is outsourced, so it is expensive. So if they are willing to pay the price for it, then we offer it to the patient. But in this particular patient, we did not do.
I would like to add, ma'am, that there are several studies which say that the metastasis risk is not different as compared to adult melanoma. And there have been couple of reports where because of micrometastasis, there have been metastasis even 24 years after the primary enucleation. So we have to keep the patient on follow-up.
Okay, thank you, Abhijit. We'll move on to the next speaker. We have Dr. Preeti. She will be presenting a challenging case on retinal blastoma.
Good morning, everyone. I'm going to present a case of retinoblastoma. This is a case of a 9-year-old boy who presented to us in November 2021 last year with leukocoria in left eye since 1 month and associated progressive diminution of vision. The informants were parents and their history was reliable. The leukocoria as well as diminution of vision was not associated with any pain, redness or trauma. The family history was negative. The child had 2 younger brothers and he was screened for the similar illness. They consulted a private hospital in Jaipur for this leukocoria where he was suspected with left eye retinoblastoma and was referred to tertiary care for further management. He presented to RPC on 1st of November 2021 last year. On ocular examination, the uncorrected visual acuity was 6/6 in right eye and 6/24 in left eye, which further improved to 6/18 on pinhole. IOP and intraocular pressure and adnexa were within normal limit. On slit lamp examination of the left eye, patient had fixed dilated pupil. Neovascularization of iris was seen. Ectropion UVA was noted, and intracameral seeds were present from 4 to 7 clock hours. On indirect ophthalmoscopy, right eye fundus was within normal limit with no peripheral lesion, and left eye showed inferomedial intraocular mass with exudative retinal detachment. On ultrasound, this inferomedial intraocular mass was 5.6 millimeter in apical thickness and 12.5 millimeter in largest basal diameter, along with calcification which was seen along medial orbital wall. On fat suppressed contrast enhanced MRI, it confirmed our findings with localized intraocular mass which was seen with RD with no optic nerve involvement or any extraocular extension. On ultrasound biomicroscopy, circular invasion of multiple tumor seeds was noted in anterior as well as posterior chamber. At this point of time, we also did examination under anesthesia, and these are the red cam pictures of the same, depicting the interior seeds in the left eye along with inferomedial intraocular mass. We advise for left eye upfront enucleation to the parents along with primary implant, but parents were keen for globe salvage therapy. Hence, a trial of 2 cycles of systemic intravenous chemotherapy was given to the patient. The standard dose for more than 3 years of age, VEC standard regimen was given. On serial examination under anesthesia, the patient showed good response to systemic chemotherapy. And this was the red cam pictures post 6 cycles of chemotherapy of the child, which showed complete regression of the tumor mass along with shallow RD. We kept the patient on close observation, and every 2 months he was called for follow-up. On subsequent visit after 4 months of stopping the systemic chemotherapy, the patient had shown relapse of tumor with reappearance of anterior chamber seeds with visual acuity diminishing to finger counting close to face, PR accurate, and patient also presented with posterior subcapsular cataract. However, the inferomedial mass was still regressed and exudative RD was present. So we again advised asked for repeat contrast enhanced fat suppressed MRI brain orbit, and it showed no definite enhancing mass lesion and no optic nerve involvement. We basically wanted to rule out any optic nerve involvement or extraocular extension, which confirmed to be negative at this point of time. And then we again offered the enucleation of left eye for the patient, secondary enucleation, but the parents did not give consent for the same. Hence, therefore, patient was planned for intracameral melphalan injection, 20 microgram with concomitant triple freeze cryotherapy at injection site under general anesthesia. Before giving the intracameral melphalan injection, this was the ultrasound biomicroscopy before the injection, which was given. This you can clearly see intracameral seeds present in both the anterior as well as posterior chamber. So this was how the drug was prepared. Melphalan injection usually come in powder form, which is of 50 milligram the vial, and we use 10 ml of this diluent, which come with this drug only. So we mix 10 ml of this sterile diluent into the melphalan and take 1 ml of this and mix it with 24 ml of normal saline. So this makes 5 milligram of melphalan, in total 25 ml of normal saline. So ultimately 0.1 ml of this solution is taken, which is 0.02 milligram or 20 microgram which is injected with the help of a 30 gauge needle into the intracameral site. After this, the patient was followed up after 4 weeks of this intracameral injection, and it showed complete resolution of these anterior seeds. As you can see, left eye vision was again hand movements close to face, pure accurate, but VR was almost like within normal limits. So this was, so we decided this is a plan of management for the patient. After this, we have decided to keep the child under close observation, and every 2 months, we'll keep the patient for follow-up every 2 months for 6 months at least. And once there is complete resolution and no recurrence of the tumor for at least 1 year, we can plan for left eye cataract surgery. Discussion. There are various pharmacokinetic studies which have shown that anterior chamber does not achieve tumoricidal dose with systemic intra-arterial chemotherapy as well as intravitreal injections for that matter. Intracameral chemotherapy is a novel technique to control these aqueous seedings. Monier et al. Described a bicameral injection technique in a pilot case of unilateral group E retinoblastoma with primary aqueous seeding. In their pilot case study, control of the retinal tumor and vitreous seeding was achieved first with the help of intraarterial and intravitreous chemotherapies, and sterilization of the aqueous seeds was achieved with the help of first cycles of 7 melphalan injection in the anterior chamber. However, they noted a relapse after 3.5 months later. So this relapse was finally controlled with second cycle of 6 intracameral injections targeting the posterior chamber. In their 5 years follow-up, the patient was tumor-free with normal vision 20/20 in both eyes and no metastasis. This is another study by Munier et al. Sorry, the same study of Munier et al. This is another study described by Boroni et al. Describing the new one-step intracameral chemotherapy technique. Actually, in this technique, they have just used, it's a one-step approach in which they have used 3-way cannula and attached to 1 cc syringes with the 3-way cannula, and with the help of a 30 gauge needle, they in a single go, they will aspirate the anterior aqueous, and with the second, after closing the valve, turning the valve, they have injected the melphalan in the single go. So in this case, they had included, it was a retrospective study, they had included 12 patients. Out of them, total 9 patients of them had shown response to the single intracameral melphalan injection, while in 2 patients, they required a second injection, which was administered 2 weeks after the first follow-up, first one. This is the take-home message. Recurrent or persistent intracameral seeds following treatment, they poses a difficult management and often leads to enucleation. Intracameral melphalan is an emerging new modality used as globe salvage therapy. However, caution is recommended with regard to proper case selection. Thank you.
Congratulations, pretty well time managed and a well managed patient.
Thank you, sir.
This patient. And one thing which you have also emphasized here, that the child need to have a very close follow-up, because the relapsing of such tumor cells in the anterior chambers has been reported in previous other study also.
Yes.
And also the child have got cataract, so like maybe if they regress, if regress is there for at least 1 year, you can consider for like later on for cataract surgery. Another issue with using melphalan is like the toxicity which can be there on endothelium also.
Yes,
so
sir.
that thing have also to be looking further
Yes, sir.
in further studies also.
Yes, sir.
Anything, ma'am, you want to add on?
Yeah, so one thing also that usually in such cases we offer upfront enucleation.
Yes, ma'am.
That is a very important message that this is not a standard treatment that we use for intracameral seeds. We usually will offer upfront enucleation because it comes under a group P, retinoblastoma. High-risk histopathology is there. So, and basically the first and foremost important goal in a retinoblastoma is to save the life. So if the other eye is having good 6/6 vision, it's a unilateral case, there's no reason why you would not opt for enucleation. But in this particular case, I mean, most of the times we spend a lot of time counseling, but in this particular case, sometimes, like it happens like in this patient that the parents were just not willing. And we were encouraged by the fact that, the posterior segment had shown a good response.
Had the tumor still been active in the posterior segment and there would have been AC seeds, then of course, we would not have tried this kind of thing. But because the tumor had responded very well to systemic chemotherapy, and we thought that now the challenge is only in terms of anterior chamber seed management, and we have seen that literature, elsewhere have, sort of dealt with these cases, and there have been reasonably good outcomes in some children. We thought it is well worth the try. But then at the same time, this child will have to be kept under very close follow-up. And because we have, again, every time the patient comes for a visit, we always sort of re-emphasize to the parents that at any stage, the child may still need an enucleation. So this is not really the end of the treatment. So they have to keep that in mind. And bilateral cases, one-eyed patients, yes, in those cases, we may be a little more aggressive in our approach and use intracameral injections, intravitreal injections, just about anything that we have at our disposal to save that eye and to save vision. But unilateral cases, it's very rare, but this is one of those cases that has responded, and we'll keep the child under close follow-up.
I would like to answer Dr. Mongre's question. I think what he meant by asking was targeted therapy in melanoma patients, right? Yes, okay. So we do have in, IRCH cancer department, we have targeted therapy but they are mainly for patients with metastasis, not as a primary treatment. And they are usually MEK inhibitors, BRAF inhibitors, and that depends on which type of melanoma from where it is arising. But it is mainly, reserved for metastatic lesion, and trials are going on. And we have these, targeted treatment even in these patients with metastasis. Because we all know that melanoma is something which is chemo-resistant otherwise, and even radio-resistant. So we do have, and trials are going on.
Can we get some clues from the initial biopsies material?
That kind of a protocol that every patient is probably not needed. Generally, when patient presents with mets, then probably the biopsy and further treatment, and that decision lies on the yes, that can be tried, and but the thing is that once metastasis is there, then definitely we have some tissue biopsy, before we proceed. At that stage also one can do, because that is the point when we think about targeted treatment, right?
Like in the previous case you were saying, from a general ophthalmologist's perspective, that kind of a case where the higher facilities are not available or patient is informed about the risks of keeping the retinoblastoma for long time, or if we have a feeling that patient can not come for the regular follow-up, do you recommend that it should be the primary enucleation?
Oh, definitely.
That is what.
If the child cannot come for follow-up, there's no doubt that we should go for upfront enucleation.
So that option should we give to the patient or we reserve with ourselves?
No, we have to explain to the patient the risks of harboring a tumor like this and not coming for follow-up. If they are unable to come, then we should definitely not try any of
Another
this.
scenario in case like exophytic retinoblastoma or kind of a hamartoma where there is a clinical confusion, posteriorly placed exophytic retinoblastoma or chondroitic hamartoma kind of a picture where the mass is on the posterior pole.
Usually we are able to arrive at a definite diagnosis.
Clinical basis.
Clinical basis. We've never had to resort to biopsy. I mean, imaging is very good these days.
In case there is no clear-cut clinical things where we are not able to make out whether it is retinoblastoma or hamartoma, then what do you suggest? Follow-up or a trial of a chemotherapy?
Yeah, so we MRI, PET scan. We do not like to do any kind of invasive procedure. In fact, coming back to that point, now that you've raised it, even in that melanoma case, we had an option of doing an FNAC, because it was like so atypical for such an advanced melanoma to present at that age. So we initially thought about the pros and cons of doing an FNAC and arriving at the definite diagnosis before doing enucleation, which is a very radical procedure. But again, the risk we thought that, and it was a non-seeing eye, and we knew that there is a mass. The parents had given consent for enucleation, so we went ahead with enucleation without doing an FNSC.
Thank you, ma'am.
Okay, thank you. So moving on to the last speaker of this session, we have Dr. Manu. He will be speaking on interesting case of choroidal hemangioma.
Good morning all. I am going to talk regarding a case of circumscribed choroidal hemangioma which presented in our RPC OPD. Our patient details: she is a 48-year-old female patient. She is a homemaker, came from Kanpur district of Uttar Pradesh. Her presenting complaint was presented at RPC OPD in 4th January 2022 with complaints of diminution of vision for the last 1 year and with gradual, progressive and painless diminution of vision. She consulted in local hospital UP and diagnosed as a case of refractive error and prescribed spectacle, and she had some improvement in vision also. But later gradual worsening of symptoms occurred and she referred to RPC from the local hospital itself in view of some abnormal fundus pathology and presented to RPC OPD on 4th January of 2022. On primary diagnosis, suspected choroidal hemangioma was made and patient referred to our ocular oncology clinic. There was no history of any systemic illness, no family history of similar complaints, no drug allergy or any addictions. On examination, all systemic examinations were within normal limit. Coming to the ocular examination, her right eye vision was 6/6 and left eye was 1/60 improved to 3/60 on pinhole, and anterior segment is within normal limit both eye, and posterior segment examination, right eye absolutely fine. On left eye, disc appears normal. There was a slightly elevated ill-defined lesion with slight pigmentary changes at the macula with subretinal fluid. This is the fundus image. On the right side, we can see the right eye absolutely fine. On the left side, disc and vasculature is normal, but there was an ill-defined elevated lesion with some pigmentary changes at the macular region with some amount of subretinal fluid, but reaching exactly at the foveal region. So to confirm the diagnosis, we suspected a choroidal hemangioma clinical picture, and we need further investigation to confirm the diagnosis. On investigation, we did a USG-B scan. On that, we got an elevated, well-defined lesion with moderate to high amplitude internal spike with acoustic solidity, which is confirmatory to the choroidal hemangioma. The largest basal diameter was around 10 to 11 mm, and apical thickness was around 3.4 mm. To confirm the details regarding the subretinal fluid, we did an OCT image, which very well showed that an elevated dome-shaped lesion with subretinal and intraretinal fluid with some kind of striatic features and disrupted outretinal layers. And this is an FA and ICG-A picture. The first image is an early phase of FA, and the second image is an early phase of ICG. FA shows varying degrees of hyperfluorescence in all phases from early phase to late phase. There is a lazy mild hyperfluorescence in the pre-arterial or early arterial phase and diffuse intense hyperfluorescence in the late phase, which is shown in the next image, and which is typical of choroidal hemangioma. When it comes to ICG angiography, there was an early rapid filling with extreme hyperfluorescence in the first minute, and the late washout phenomenon, which is typical of choroidal hemangioma, seen in this image also. And OCTA, which helped us to analyze each layer of retina regarding the vascular pattern. There in the fourth image, that's the deeper layer, that's choriocapillary layer, which showed a hyperreflective areas of loss of vasculature and abnormally or irregularly arranged vascular pattern, which is also suggestive of choroidal hemangioma. So came to our diagnosis, right eye was absolutely fine with normal, and left eye circumscribed choroidal hemangioma involving the macula with subretinal fluid. So next comes to the treatment. We have multiple options regarding treatment of a choroidal hemangioma. So whether to go for a treatment or not, that depends on the symptoms. If the patient is absolutely fine with no symptoms, we don't need to do anything. We just need to closely observe since it's a benign vascular tumor. But if the patient is having any symptoms, as in this patient, there is significant vision loss. So we need to think about to intervene. So we have laser photocoagulation, transpupillary thermotherapy, photodynamic therapy, multiple radiation therapies like plaque brachytherapy, external beam therapy, or proton beam therapies. So we need to analyze and find what's the best option for these patients. So regarding the 3-4 options available for or suitable for this patient, from these 4 lists, we rule out, we have decided to remove laser photocoagulation plaque brachytherapy, because since it's in the foveal region, laser photocoagulation can create so much of scarring and further reduction in vision. And brachytherapy, since it's a posteriorly located tumor at its exactly in the foveal region, we decided to avoid, and it's need for, 2 surgeries, and there is a risk of radiation maculopathy. So we have remained with 2 options, that is TTT and PDT. PDT ideally is the best option for a subfoveal tumor, but since it's not, verteporfin dye is not available, and sometimes patients are not affording for PDT, we decided to go ahead with TTT. So what we did is left eye transpupillary thermotherapy was planned, and we did it in 6 sittings for the last 6 months. So TTT parameter, since it's a foveal region, we decided to keep a lower power, that's around 250 to 350 milliwatt, and we did it in 6 sittings. So this is what we achieved after around 6 sittings of TTT. This is the first image is the pre-procedure image, and this second one is after 3 cycles of TTT, and last one is after final image. So there was significant reduction in the tumor size and subretinal fluid with some amount of inevitable scarring. So it's the OCT images after 3 cycles and 6 cycles of TTT. You can very well see in the image the dome-shaped tumor size significantly reduced, and subretinal or intraretinal fluid is also reduced, and at least some amount of foveal contour we gain. But scarring or outer retinal layer disruption is not at the region of scar. So we achieved a vision of from 1/60 to 6/36 with a satisfied patient. So coming to the discussion part of a circumscribed choroidal hemangioma, it's a benign vascular tumor with presence in middle-aged adults with progressive diminution of vision, with complaints of diminution of vision, metamorphopsia, floaters, and visual field defects, which all depends on the amount of subretinal fluid and the location of the tumor. The main aim of treatment is to resolve the subretinal fluid and gain some amount of vision, and not the reduction in the tumor size, because that's sometimes gained with the treatment but not the primary goal. Treating subfoveal lesion needs extra precaution, as it may directly damage the fovea and affect the final visual outcome. Chronicity of subretinal fluid, tumor location, initial visual acuity have strong correlation with final visual acuity in the management of macular circumscribed choroidal hemangioma. Even though photodynamic therapy is considered as a safer option for subfoveal hemangioma, TTT can be an effective alternative in selected cases with similar final visual outcome. It's an effective method that results almost 100% resorption of subretinal fluid with a decrease in tumor height by at least 42% in different studies. In our study, we almost completely flattened the tumor. Treatment can be stopped once the fluid resolved, and we don't need to wait to complete regression of the tumor mass. TTT may be avoided in subfoveal choroidal hemangioma because of the risk of damage to the sensory retina, but extrafoveal portion of the tumor may be treated. So take-home message is transpupillary thermotherapy can be an effective and alternative modality of treatment to PDT in selective cases of circumscribed choroidal hemangioma in symptomatic patients. Proximity to the fovea and optic nerve may not be a predictive of poor post-treatment visual acuity. Thank you.
Thank you, Dr. Manu. Nicely presented and beautiful slides. So in this case, we are a little bit skeptical to treat the TTT on the fovea of parafoveal area. So however, there was fluid was there, and then patient vision was significantly down. So we did consider for TTT, but TTT in macular area usually should be avoided if possible. And also, like if photodynamic therapy that verteporfin is available, then this is the first choice of treatment. And also we go very slow on the power of TTT there, start with around 200 to 250, and with multiple sessions. That's what we have done in this case. Any other question or anyone want to input? Yeah.
Yes, ma'am. Ma'am, because a patient is already having 1/60 vision, so we expected some gain in vision after TTT, because anyway patient was also motivated. If the patient is asymptomatic, we don't need to intervene at all. But since it's in the foveal region or slightly extrafoveal with subretinal fluid significantly in the foveal region, that's why we decided to go ahead with the procedure. Otherwise, if the patient is at least some good gain, good vision, we don't need to intervene ideally. Thank you.
Okay, thank you. We are moving a little bit behind the schedule now. So we'll move to the next third session. And for this, I will invite Professor Seema Sen. She is the professor in ocular pathology and in charge in ocular pathology in RPC. She will be speaking on immunohistochemistry as a diagnostic tool in ocular oncology, a very important topics for the ocular oncology as well as the plastic. Yeah. And I also request if Madam, you can please come over here. Ma'am, Nila ma'am, you want? Yeah, sure.
A very good morning to everybody. So in the previous session, I think most of the students have used immunohistochemistry, and we all know that it's a very powerful tool. So I will be just revising everything which was done before. So what is the role of a pathologist in any hospital? So our main role is to make a tissue diagnosis. And in 80 to 90% of the cases, we are able to make a diagnosis with the help of a simple light microscope. That is all that we need. So what does a pathologist look for? When we get a tissue, we look for, is the tumor producing anything? If it's producing melanin, like you can see in this, so definitely the cell of origin is a melanocytic origin. Then we look for patterns. The pathologists look for patterns and designs. So if the tumor is forming a certain geographical pattern with peripheral palisading, it's very simple. It's a simple case of a basal cell carcinoma. Then if it's producing keratin, like these pearls, keratin pearls, then it's a squamous cell carcinoma. And if there are vacuolated cytoplasms in an eyelid tumor, this is most likely going to be a sebaceous gland carcinoma. And if we see rosettes in a round cell tumor, it's a retinoblastoma. So in 80 to 90% of the cases, our task is simple. We just make a diagnosis with a simple light microscope. However, if this is not possible, we have a panel of basic immunohistochemical stains, and I think most of the residents know. If the cytokeratins are positive, it's an epithelial origin tumor. That means it's a carcinoma. If the mesenchymal marker, that is vimentin, is positive, it's most likely going to be a sarcoma. If the hemopoietic marker, the LCA, leukocyte common antigen, is there, it's either a lymphoma or a leukemia. And the fourth common broad marker is a melanocytic marker, which is S100, HMB45, and now more recently SOX10. So these are the basic four immunohistochemical stains that we use if we are not able to make the diagnosis based on light microscopy. So now going to the pathology of immunohistochemistry. So as the name suggests, it's an immunohistochemistry. So immuno means an antigen-antibody reaction, and histochemistry means we are going to visualize the color change. So what are the antigens and what are the antibodies? Antibodies we have to purchase, and the antigens are within the cell, but we cannot see them by the light microscope. So these antigens are called intermediate filaments. So whether it's a CK, cytokeratin, or it's a S100 protein, or it's an HMB45, all these are antigens which are present. Sometimes they can be seen by the light microscope if there is melanin production or there is keratin production, but if it's not there, if it's a poorly differentiated tumor, we have to put these antibodies onto the sections, paraffin sections that we have, and then visualize it by the antigen-antibody reaction by developing a colored protocol. So now it's become a very powerful adjunctive tool for a histopathologist, and it definitely increases the accuracy. Otherwise, we as pathologists will be reporting them as poorly differentiated malignancies. And it does tell us about the lineage of the tissues, from where the cells are originating. So what are the prerequisites for performing immunohistochemistry? So normally we get tissues from the operation theater in 10% formaldehyde, But for immunohistochemistry, it is very important that it is not only formalin fixed, but it has to be buffered formalin, a neutral buffered formalin, because the one which is commercially available, it's usually very acidic. So we have to put in a buffer and make it a buffered formalin. And the second thing is that the sections which we cut, the technicians which we cut, it has to be on polylysin coated slides. Polylysin is a special adhesive. If we don't use polylysin, the sections are going to float away. So we need to cut the sections on special polylysin coated slides, and the cost is approximately, I think, 80 to 100 rupees per slide. So now coming to the methodology, so this is the primary monoclonal antibody which we purchase. It could be cytokeratin, it could be HMB45, and it adheres to the antigen which is present within the cell. This is usually a 4-hour process, but it can be an overnight process also. And then in the second process, we put secondary antibodies which are biotinylated. So after this secondary reaction, we have to develop a color now. So how do we develop the color? Because unless we see a color, we will not be able to see it on the light microscope. So we do the avidin biotin peroxidase complex method, and by this we are able to visualize, and usually the coloring agent that we use is DAB, diaminobenzidine, and develops a brownish color. So as I told you, it has to be 10% buffered formalin. And the second thing that we have to be, that we as pathologists should know, that when there is an antigen-antibody reaction, similarly formalin also reacts with the proteins which are there in the tissues, and the antigens get hidden. So how do we make these antigens visible for the further techniques? This is called antigen retrieval. So in antigen retrieval, what is meant is that bonds which were formed between formalin and the proteins, these need to be disrupted. And that is why we need polylysin coating. So these bonds are disrupted by antigen retrieval techniques, and usually they are done in the microwave. That means we have to heat the section in buffers and then make the antigens available for the antibodies which we are going to put. So now coming to the basic immunohistochemistry and its application in pathology. So we can broadly classify the use of immunohistochemistry into 4 broad categories. First is in the diagnosis of small round blue cell tumors. The second is in the diagnosis of spindle cell neoplasms. The third is in the diagnosis of poorly differentiated malignant neoplasm. And the final one is the unknown primary. And there's a fifth one also. We can also look for various the viruses which are present. I'll be coming to that in the last part. So this is the battery of antibodies that should be put for every malignant round cell tumor. So basically a panel of at least 6 stains. Desmin for a rhabdo, synaptophysin for a RB, neurofilaments for a neuroblastoma, LCA for lymphomas, MPO for leukemias, and MIC2 for a PNET. So as pathologists, we cannot just do one stain and say it's Desmin positive, so it's a rhabdomyosarcoma. We have to say that it is not the other things also. That is equally important. So this was a man with left orbital proptosis, and as I said that it was a malignant round cell tumor, and leukocyte common antigen was positive. And it was also negative for the rest of the panels. That means we ruled out the other markers. And further, whenever it's LCA positive, we need to classify further. It is a non-Hodgkin's lymphoma. So what type of a non-Hodgkin's lymphoma it is? So normally it is a B cell non-Hodgkin's lymphoma in the orbit, and it is classically a maltoma. I will not go into the details, but there are many other antibodies we resort to classify them into low-grade and high-grade non-Hodgkin lymphomas. The second important thing that you all should know is that when we make a diagnosis of lymphoma, we also rule out a reactive process. So how do we rule out a reactive process as pathologists? It has to be a monoclonal proliferation. That means all the cells are B cell type. If there was an admixture of B cell and T cells, that means CD20 and CD3 cells, then it can't be a lymphoma. It's a polyclonal population. So this reactive polyclonal population has to be separated from a monoclonal proliferation, which is a non-Hodgkin's lymphoma. So just to highlight this, I'm just showing you a case of a lacrimal gland mass which had come, and as you can see, the lacrimal gland acini were all destroyed, and there's a lot of fibrosis, and we have these residual lymphoid aggregates, and a lot of inflammation, which includes lymphocytes, plasma cells, and eosinophils. And whenever there is a polyclonal proliferation, we should always do an IgG4 staining, because very often it could be just an IgG4 orbitopathy, and more than 8 to 10 cells per hyper field makes a diagnosis of IgG4 orbitopathy, and it has to be corroborated by the clinicians by the blood test, serum levels also. Now coming to the next round cell tumor. So this is another, usually these patients presents with bilateral proptosis, and if you do a peripheral blood film examination, you will see the blasts, and you don't need to do a biopsy actually. But in case you do a biopsy, it will be myeloperoxidase positive, and it's going to be a case of a leukemia. This might be LCA positive, or if it's a myeloid leukemia, it can be negative. So LCA negative cases does not rule out a leukemia. We still have to go ahead and do a myeloperoxidase for myeloid leukemias. So another case, this is another child with proptosis, characteristic spindle-shaped cells. So this gives us a hint. This could be rhabdomyoblasts, and desmin is positive, and myogenin, and the rest of the 4 markers are negative. So this was a case of an embryonal rhabdomyosarcoma. Another case, in this light microscopy in this child, we saw shells with different appearance. They were not really round nuclei, but they were slightly grooved nuclei. And there was also an admixture of eosinophils, lymphocytes, and neutrophils. So now here comes the problem for the pathologist. Is it a reactive process, or is it a tumorous process? So now we have to correlate with the systemic appearance. So this child had multiple osteolytic lesions, and CD1A was positive, and S100 was positive. So what's the likely diagnosis? So this is a Langerhans cell histiocytosis. So all polyclonal proliferations might not be reactive. They could be cases of histiocytosis X. This is an electron microscopic picture. So next, another case of bilateral proptosis. In this, CD1A was negative, and CD68 was positive, and then correlating with the systemic features, a diagnosis of a Erdheim-Chester disease was made. Now finally, coming to the last of the round cell tumors, this was a biopsy from an orbital mass in a child, and the history told us he was enucleated earlier, so it was obviously a recurrence of a retinoblastoma, and it was positive for synaptophysin and neuron-specific enolase. So this is a recurrence of a retinoblastoma. So this is another case of a metastatic round cell tumor, and this child had got an adrenal mass. This was neurofilament positive, NAC positive, synaptophysin positive, and on systemic examination he had an adrenal mass, and so a diagnosis of a metastatic neuroblastoma was made. So it's not necessary that always it's going to be a primary case in a round cell tumor. One should have this thing in mind, that always examine the child systemically and to rule out metastasis. Now this is the larger list for spindle cell tumors, and as you see, most of them are for sarcomas, and 2 of them are epithelial markers, which means that a sarcoma can, and a carcinoma can mimic a sarcoma. So I'll quickly go through these since I've run out of time. So this was a case of a neurofibroma, which was S100 positive and SOX10 positive. Another case of a spindle cell tumor again. This case had prominent vascularity, as you can see. This was CD34 and STAT6 positive. So any guesses? STAT6 positivity is specific for what? This is a very particularly specific marker for a solitary fibrous tumor. So earlier, most of these cases were being diagnosed as hemangiopericytomas, but now this term is no longer used. So all of them are now solitary fibrous tumors, and they have varying grades of malignancy, from benign to malignant. This is an optic nerve glioma, located close to the optic nerve, and GFAP positive, rest all negative. This is another case of a spindle cell tumor with whirling. Whenever there is whirling and the tumor is near the optic nerve, you always think of a meningioma. These are EMA positive and cytokeratin positive. So this was the poorly differentiated tumors I was talking about. All spindle cell tumors are not sarcomas. It could be a spindle cell or a sarcomatoid squamous cell carcinoma. So in the panel of sarcomas, one should also include cytokeratins and EMAs. This is a third utility of immunohistochemistry in the diagnosis of poorly differentiated malignancies, and very often we have these monomorphic looking cells, and when we do the entire panel, everything is negative, but HMB45 is positive. That means it's an amelanotic melanoma. So now coming to the last utility of in immunohistochemistry, it is very useful in the cases of unknown primary. Very often the patient comes with a primary orbital or an intraocular mass, and the primary has secondary mass, but the primary is not manifest. So now the origin could be in the GIT, it could be in the ovaries, in the thyroid, in the breast, or in the ovaries. So for each region there is a specific marker. CK7 is for GIT origin, for lung it is TTF, for breast it is GATA3, for ovarian it is PAX8. So IHC is really useful in these cases if the primary cannot be detected. So just this case which presented as a choroidal melanoma, and we got this intraocular mass and we thought it was a amelanotic melanoma, but HMB45 was negative, S100 was negative, and it turned out to be positive for TTF, that means thyroglobin was positive, and CK7 was positive. And on PET scan, there was a mass in the lungs. So this was a primary lung carcinoma with choroidal metastasis. So this is the last part, the detection of infection agents, but micro is better at this than pathologists, and I think immunofluorescence is much better. So we don't do this as a diagnostic modality, just as a research we've done for chlamydia and HPV and HSV. And finally, now as a prognostic indicator, whenever we make a diagnosis, we need to grade the tumor, and that is how it's going to be treated. And we do the grading by counting the number of mitotic figures. Is it less than 5 per 10 hyperfield or more than 5 per 10 hyperfield? But if the mitoses are not evident, then we need to resort to this MIB1 or the proliferative index. So in this, all the cells which are in mitosis, they stand out, and it's easier to count these cells. So if the MIB1 index is more than 10, it's going to be a high-grade neoplasm. So this helps the oncologists in the management. And of course, for breast cancer and other malignancies, ER/PR and HER2 receptors, these are very important and give a prognostic implication to the tumors. So IHC is indeed very important. And to conclude, as it is very evident that immunohistochemistry in the present day is a very important tool for the pathologist, but the only thing is that it's expensive. You need a backup from a well-formed pathology department with lots of funds, which you can get in a large private setup or a government institute, because each antibody costs around 40,000, and the secondary antibody with the avidin biotin costs about 1.5 lakhs. And then we need to have a trained, dedicated technician, because each step, the antigen retrieval, the cutting, has to be done by a trained pathologist. So it's not simple, and I think many of the patients, institutes are outsourcing also, like Lal's lab and all. Just send the tissue to Lal's lab and they'll do it. And there also you need an experienced pathologist, because if a pathologist cannot interpret a light microscopy, he'll not know what panel to do. So selecting the panel is important, and then of course interpreting. It should not be false positives and negatives. Thank you.
Thank you so much, ma'am. That was very informative then about the role of IAC. And then in fact, we are so fortunate and blessed that we have such a highly experienced pathologist. And also, like, I would also like to say that, like, being an ocular oncologist, like, our treatment starts from the pathologist and also ends from the pathologist only. So thank you so much. And on the light, like, if you have any question, ma'am, yeah.
This is for everyone sitting here. Ma'am, sometimes we get reports saying that tissue sample is not sufficient or artifacts are there. So like the person who is taking out the biopsy should know what is the minimum size of tissue.
You're talking
we
about
are
light microscopy or immunohistochemistry?
otherwise also
Generally.
in general we get report that the tissue sample was not sufficient. So just for people sitting here, I want to
See, the problem in the size of the biopsy is that if it's a big mass, if it's a 2 centimeter big mass, I'm just giving an example. If it's a 2 centimeter big mass and we get a, say, a 2 or 3 millimeter biopsy, so we as pathologists might call it inflammatory or neoplastic, but it's not representative. And you as surgeons can't give a very big biopsy. So it has to be an optimal, say about 0.5 would be ideal, I think, the smallest. 0.5 centimeters.
Okay.
1 centimeter
Around
is
5
ideal, but I
millimeter.
think in the eye it's not possible to have a 1 centimeter big tissue.
Sometimes we can have in huge, or periorbital tumors.
Because nowadays, although we are not doing molecular studies at all, but as of now, from the IRCH, they're very often asking for blocks and all, and they're outsourcing for molecular studies.
Okay.
So if we have big tissues, it's good because the tissues are preserved in the block and they will be in the department and they can be used later on also for research purposes.
And how to avoid the artifacts part of it? Like, in what way this, as a surgeon?
Artifacts, actually, the main artifacts that we as pathologists encounter, one is that cautery, when you use the cautery. So that destroys the cells.
So
we
you
can't
mean
see
to
the
say
living.
that we should avoid the use of cautery while taking out the, biopsy tissue?
The margins is all right, but the main tumor,
Main tumor.
so that destroys the cells. So if they're not living, we can't diagnose. And the second artifact we get is the crush artifact sometimes. So these, I think someone is picking up the tissues with a very sharp forceps and they just crush the tumor cells. So we cannot make a diagnosis. We have to see the morphology, like I said, the patterns of cells and how the cell is looking like. So if it is crushed, then we can't do anything about it.
And suppose we cannot take out sufficient, then is there any other way to see the cells, like flow cytometry or something helps?
Yeah, you can do an FNAC or a cytology, then the diagnosis will be purely based on the cellular features.
Okay.
And as you know, the gold standard is histopathology only. Cytopathology can say possibly it's a retinoblastoma by doing markers and synaptophysin and all that.
But finally we have to do a biopsy.
Finally, it is always good, unless it's a very good aspirate and we get a lot of cells in the, because we have a cytospin here also.
Mhm.
So if it's a tumor which you can't do a biopsy, FNAC, intraocular FNAC, like we do for intraocular lymphomas and intraocular tumors, the cytospin gives a very good cellular yield. So that's the best option if a biopsy is not possible.
Okay, thank you so much. That was really wonderful, ma'am.
Yeah, ma'am, really wonderful. I know time is running out, but I just had one quick question, ma'am, please. You showed that when the primary site is unknown, you have to do those different markers. So if the primary site is unknown and we are suspecting a metastasis, do you have a panel of markers which like covers lung, ovary, whatever, or you start with one and then go to another? Like
Actually,
what's the...
we are just building up the entire gamut. So we take the help of our sister department or brother department in main pathology.
Oh, okay.
They have the entire, and usually they are supportive, and we get the stains done. Like this TTF was done in main pathology, we don't have TTF, but we have CK7. But ovarian like PAX10, PAX5 and all, we still don't have, because they're so rare,
right,
and the cost is quite a lot, so it's not really worth it. And the antibody expires by the time the next patient is going to come.
Yeah.
So it's not cost effective. But we managed to get it done from there.
Thank you, ma'am. This is wonderful.
Thank you, ma'am. Yeah. So now it's my privilege to welcome and invite Professor Neelam. She will be speaking on the eyelid retraction, the etiology-based management.
Where is my talk in here? I can't see.
Session 3 पर ये move कर रहा है ये मैम का talk
बैक करिए तू मैं देख लें
कहाँ पे कॉपी हुआ है
डेस्कटॉप पे तो नहीं था
हो सकता है डेस्कटॉप में
नहीं है बंद करें
पेन ड्राइव में है बट मैंने ट्रांसफ़र किया था सो वेयर इट इज़
ये है मैम ये है
हाँ ये इसमें
which one PPT
This one, PPT. Thank you. Acha, okay. Good afternoon, everyone. So, I'll be talking about eyelid retraction, etiology-based management. So, why etiology-based? Because generally when a patient with eyelid retraction comes to us, we think that it is mainly because something's gone wrong with the LPS molars and we have to do some lengthening procedure, but it's not like that. So this is what my focus would be today. So eyelid retraction, we all know, is defined as increase in vertical palpable aperture or when there is asymmetry of more than 1 mm in unilateral cases, or if there is presence of scleral show commonly seen in thyroid eye disease, very typical, we all are aware of. This other patient is of left eye congenital eyelid retraction. So evaluation is very important. We should know whether it is congenital or acquired and duration of lid retraction, progression, because we want at least the lid position to stabilize for 1 year before we really go ahead with any kind of, surgical procedure. Then old photographs help sometimes, when a patient is not really aware of the lid retraction. Then severity grading is very important. This will let us know what exactly we have to do. So the severity grading for upper eyelid, mild retraction is 1 to 2 mm, moderate is 2 to 5, severe is when it is more than 5 mm, and for lower lid, mild retraction is 1 to 2 mm, moderate is 3, and severe is more than 3. So normal lid position, we all know the upper lid, it rests around 1 to 2 mm from the superior limbus, and the lower lid, it rests exactly at the lower limbus. So now etiology based, before I go ahead with the management, we should understand what are the various lamellae in the eyelid. So here I want to highlight that from eyelid margin till the insertion of the levator muscle, the eyelid has two lamellae, the anterior lamellae, which is skin and orbicularis layer, and the posterior lamellae, which is the tarsoconjunctiva. And as we go above, there is one more addition, which is middle lamella, and which is basically LPS molars and septum complex, and corresponding to this we have structures in the lower lid also. So where there is purely anterior lamella which is affected, which means the skin and the muscle layer, the causes we all know are generally burns, trauma, chronic dermatitis, or any other chronic skin diseases can lead to this problem, and primarily we diagnose these patients as cicatricial ectropion. But if we see closely, there is a component of lid retraction also, as you can see in this lady with the very symmetrical bilateral thermal burn injury. And then the management, generally what we do in patients with diffuse scarring is skin grafting or sometimes flap procedure. So posterior lamella, again, if that is affected, which is tarsoconjunctival layer, so generally we see a cicatricial entropion. But then we have to see if there is any scleral show, because that will change the management. The causes we know in younger population, generally we come across is post SJS, and in older population it's usually trachoma, though there can be other causes also. And if there is lid retraction, we have to augment the posterior lamella with the use of mucous membrane graft from the lip, which we commonly do here, or cartilage graft or hard palate graft. So we have several options, and what we can do is that we can just give incision in the tarsus somewhere midway and place the graft and also correct the entropion part of it with the help of everting sutures. So middle lamella is something where I've already said for the upper lid it is the levator, molars complex and septum, and in the lower lid it is inferior retractors and the septum. And causes, the most common cause we all know is thyroid eye disease, then but it can be post-surgical after overcorrection of ptosis surgery, and commonly in squint surgery if there is inferior rectus recession more than say 4-5 mm, if it's done, then there can be lower lid retraction in such cases. Rarely it can be post-trauma, post-inflammatory. So this is typical case of thyroid eye disease, and on the right hand side you can see this is overcorrected right eye ptosis. I'll be showing surgical video of this patient, how this was corrected. Then coming to the surgical management of middle lamella, since we know middle lamella now, so we know that we have to basically either weaken the retractors or lengthen it. So if there is a mild retraction of say 1 to 2 mm, you can just do a little bit of LPS weakening surgery by tarsotomy. I'll be showing a video. Muller's excision will help us in bringing down the lid by 1 to 2 mm. Then LPS recession without cutting horns. If it is moderate retraction, then generally we have to do combination of above techniques, or we can even do marginal myotomy to weaken the levator muscle, or we can do LPS recession with cutting horns. So cutting horns is again important, especially in thyroid eye disease, the lateral part of it, if there is lateral flare. Then severe retraction, which is more than 5 mm. It's important that we place a spacer, because spacer will give us more predictable results. So spacer, we have many spacers, and I will not go into depth of that thing. And then in thyroid eye disease, surgery full thickness transverse blepharotomy, which is specifically described for thyroid eye disease, when it is severe, say 8-10 mm, it really works. So I'll be showing a video on this also. This is the patient, though there is a skin fold we can't see, but he had around 7-8 millimeter of upper lid retraction, and below picture you can see this is after full thickness transverse blepharotomy procedure 1 month post-op. So you can see that ptosis generally doesn't happen in these patients, because there is so much tightening of the LPS, septum, molars, so this technique really works very well in these patients, giving good results. So this is a video. I've used word modified because I'll show you what was the modification. We know classically it is complete full thickness cut which we give in these patients, and it's always better to go layer by layer, cut it at the lid crease level. So we cut it, we split the orbicularis layer, and so after that we expose further the septum. Cutting of septum again is very important, because septum is generally thick and tight in these patients with thyroid eye disease. Until and unless we open, every layer will not really get very good outcome. So after disinserting the LPS, cutting of horns is very important, and you have to cut it more aggressively on the lateral side if there is lateral flare. Then the modification I'm talking about is to leave around 5 to 6 mm of conjunctiva attached to the tarsus, and then on both sides you completely incise the conjunctiva till the lateral and the medial side. This basically step helps in preventing the flattening of the middle of the contour of the eyelid. So this procedure, this modification really helps, and in the end we just have to close the skin. And a traction suture helps, because in post-operative period, if you want, you can keep the traction on, and for say 1 to 2 weeks. So now coming to the overcorrected ptosis surgery, in this patient, if you see, right eye overcorrection is there. Now in this patient there was a difference of 2 millimeter in MRD1, and so that I had to correct. Then the other important thing which is very important in ptosis correction is the symmetry of the lid crease and lid fold. So if you see here, there is an incision which was given very close to the eyelid margin, which was around 2 to 3 millimeters. So I had to shift this lid crease to the level of 7 mm so as to have a good fold in the post-operative period. So this was a very simple surgery, tarsotomy with levator resection, which was done. So there was 2 mm correction I wanted, so I had, recessed by double the amount, which was 4 millimeters. And so this is a very short video on that. Since this was post-surgical, so scarring was also present, so most of the dissection was, sharp. So this is done transconjunctively. You give partial thickness cut first, around 1 to 2 millimeter from the superior tarsal border. Make it full thickness. It's always better in the lid to go layer by layer, cutting. So we have to cut this through and through from the medial to lateral side, full thickness tarsus. Now what we are left with tarsus and the muscle, the LPS muscle. Now you see most of the dissection are sharp and little bit dissection, not much also. We just want 2 millimeter droop. So now I have recessed 4 millimeter, and where I wanted the lid crease to be, there I am taking out this double armed 60 silk suture, and similarly 2 more sutures taken out. Now this suturing technique will help us in giving a crease which is higher than the crease which you can see otherwise. And so if you see the post-op picture on the right hand side, so the position of the lid has changed, and even the lid fold has shifted little up, and in down gaze you can see the sutures are still there. Generally I do suture removal at 3 weeks post-op. So because I want a good adhesion and formation of lid crease. So if you do very early suture removal, then lid crease will not stay. So it's mainly because the adhesions are there that it will stay long, there. So in this patient you can see it has been shifted superiorly. So, in very interesting case I would like to show here. This was a baby presented 5 days old like this, with the eye fixed in the hypertropic position, and with hardly any extraocular movements, and he had a lower lid entropion as well as lid retraction. So on MRI we found out there was fibrosis in the orbit, even the muscles were very thin. So this is a known entity, congenital orbital fibrosis, which is non-familial, non-progressive. That is the best part, that it is non-progressive. And patient can present with enophthalmos, proptosis, eyelid retraction, entropion, restriction of extraocular movements. Most of these features were there in our patient. And imaging was also very typical. Very few case reports are there, but if you see imaging, it is so typical. Like when I did review of literature and when I saw the MRI of these patients, I was absolutely sure that this is orbital fibrosis, because this was the first case I had seen in my career. But the previous 2-3 reports showing the imaging was so much typical that I was sure that what we are dealing with. So in this patient, first the squint surgery was done, the hypertropia was corrected, followed by that around 2-3 months later, I did the eyelid surgery, which was inferior retractor recession, completely disinserted and recessed, and the correction of entropion was also done. This is again a 1-minute video. So this is the pre-op. Intra-op, you can see the lid retraction and so much tightness of the lid. So each and every layer you will see that there is a lot of fibrosis, very deep inferior fornix, and most of the dissection was sharp in this case. I had released all the fibrosis till the orbital rim. Now I'm cutting the inferior retractor again layer by layer, because there is so much fibrosis that we don't know which layer will land up. So this is I'm disinserting from the lower border of the tarsus, both sides. And again there is a lot of fibrosis and lot of blunt and sharp dissection I had to do, but I ensured that I did all the dissection till the orbital rim, so the inferior retractors will not come back. And so this is the retractor here, left alone like that there, and then the conjunctiva was sutured to the tarsus. Now I am passing the everting suture close to the eyelash line, so that there is adequate eversion. You can see the lid is so loose now, and this is 1 month post-op, and you can see still there is horizontal squint, which was later on corrected. So initially only vertical part was corrected, and then I did this surgery, and then after that the horizontal part of the squint was also corrected. So every case is different, so we have to see what exactly is the underlying etiology. Every surgery has its own complications, so if we don't tackle the lateral flare, then we'll end up with persistence of lateral flare. So cutting of lateral horn is very important. and complete cutting of lateral horn, and that also lateral most. It should not be like away from the lateral canthus, then the effect of your surgery won't come. So that is one thing. Then other thing is that sometimes they can be flattening of the medial side of the lid contour. If you see the post-operative 2-month period, you will see the difference. There is flattening. So not much cutting of the medial side of the horn. So you can even avoid depending on the the amount of lid retraction. But yes, if there is lateral flare like in this patient, if there is lateral flare, we have to cut the lateral horn when we are doing any kind of lengthening surgery or whatever we are doing. So take home message is that management of eyelid retraction depends on the amount of retraction, underlying etiology and lamella affected. Complete evaluation is very important, and explaining about the possible complications again is very important. Thank you so much.
Thank you so much, ma'am, for your comprehensive talk. Any questions?
No, it's just not needed. If it is a case of thyroid eye disease, severe lid retraction is just not needed. No, not at all. He was doing absolutely fine. The amount of conjunctiva, in fact, was more, though it was fibrotic, but more because the fornix was very deep because of the fibrosis and that pull. So conjunctiva was sufficient enough. Sufficient enough. So there was no need for that. This particular entity, if you read, this is non-progressive. So that is the best part of it, that it is non-progressive. So whatever we have done, so probably should stay. That is what we expect.
And you do give a steroid course before operating a case of thyroid eye disease for lid retraction?
No, steroid course is given if there is, clinical activity score is there, which is significant enough to, warrant any steroid. But yes, people have tried giving steroid in, congestive phase retraction. But I have done work on, the inactive stage using Botox. But yes, that is described, can be given in patients with, but they should have, active stage. Then only it will work. Otherwise, it won't. You are talking about oral or injection?
Oral.
Oral is not indicated until unless there is activity.
And what is your opinion about using Botox in these patients?
Botox works quite well. There was hardly any patient where there was overcorrection, there was ptosis. But yes, the response is very variable, and we need to see how much we need to inject and where. Because if there is significant lateral flare, then probably I'll inject more on the lateral side than in the center. Medially, mostly it's not required. So we give in the center and the lateral part, but the amount depends on how much is the flare.
What is the maximum units you use?
15 units.
15, okay. Thank you.
Thank you so much, ma'am, for your talk.
Thank you.
May I now call upon Professor Bhavna Chawla, ma'am, for her talk on management of advanced retinoblastoma.
So I don't know if you really have any stamina now to listen, or everybody wants to break for lunch. But I'm not letting you go before my talk is over. So thank you all for your patience. This is this one. Okay. All right. So I'll keep it quite brief because this is quite an exhaustive topic, but I'll try to cover some important points over the next few minutes. I'm going to talk about management of extraocular retinoblastoma. So we all know, we are very familiar with this, that the goals of therapy in retinoblastoma are life salvage, globe salvage, and vision salvage in that order. Luckily today, because of so many new technologies and targeted chemotherapy and other things that we have in our armamentarium, we are able to save vision in some of those few fortunate patients. But by and large, we still get patients in very advanced stages where light salvage and globe salvage are a priority. So how common is extraocular retinoblastoma? Really, why are we talking about it here today? So if you look at this study that was published from our center a few years ago on clinical presentation and survival of retinoblastoma in a cohort of about 600 children, we found that unlike the West, in our clinical scenario, extraocular retinoblastoma is seen at presentation in more than 1/4 of the cases, which is like, quite significant, and therefore we really need to address this issue on a priority basis. And if you not just look at India, but if you look at Asia, then Asia itself carries 43% of the global burden of retinoblastoma. So really targeting these patients in countries like India and China will actually make a difference to the outcome of retinoblastoma all over the world. Now, as we all know, extraocular retinoblastoma is a major contributor to mortality. Once there is extraocular spread, it has been seen in many different studies that the risk of mortality is much higher, more than 5 times as compared to intraocular tumors. Now, extraocular retinoblastoma clinically is not very difficult to diagnose because children usually present with typical features of proptosis. There may be pain redness, there may be associated leukocoria. If you're still able to see the eye, there might be a staphyloma. Very often they present with an orbital mass. Sometimes in advanced stages it's a fungating mass, and there is accompanying cervical lymph node enlargement. So whenever we suspect extraocular retinoblastoma clinically, the first and foremost thing that we like to do is a contrast MRI of the orbit and brain. And why do we do that? Yeah, we want to confirm the diagnosis because we're not doing a biopsy or we don't have any histopathological evidence in this case. It also helps us to define the local extent of the disease because MRI, as you all know, is a very good imaging modality for detection of soft tissue invasion, unlike CT, and detection of intracranial PNET also in some cases, like also cases of trilateral retinoblastoma. Sometimes clinically may present as bilateral, but when you do an MRI, you find it's a trilateral. Of course, that's very rare, but that's also one scenario where MRI can be useful. And here I also want to say that many times we see that children have had a CT scan before they come to our center, already had, but by and large in our own imaging protocol, we avoid CT scans for retinoblastoma. One is mainly because ultrasound is able to pick up, CT is good for picking up calcification, but ultrasound per se is also good for picking up calcification in about 80 to 90% cases. So really CT is not required for that. And as far as the soft tissue extent is concerned, MRI is much better than CT. And more than that, CT is a procedure that also carries radiation risk. And these cases have, like 1/3 of these cases have germline mutation. Of course, all bilaterals have germline mutations, but again, when it comes to unilateral, phenotypically they may be unilateral, but they may still be carrying a germline mutation. So in such cases, it is best to avoid CT. So if you suspect a patient of retinoblastoma that comes to you, it would be better, if possible, to do an MRI rather than go for CT. Now, beyond that, of course, we need the help of our pediatric oncologists because a metastatic workup is needed at baseline. They do a hemogram, liver and kidney function test, ultrasound abdomen, chest X-ray, bone marrow biopsy, and CSF fluid examination is also done because these are the most common sites for metastasis for extraocular retinoblastoma. And we can also do a whole body PET CT scan in these patients if it is indicated. So now coming to the management of extraocular retinoblastoma, we are using the multimodal approach at our center as at many other places where it is a fairly standardized approach now that has been used that includes a combination of intravenous chemotherapy, surgery and radiation therapy. So how we do it is that when the child presents to us, we initially do an MRI, and once we are sure of the diagnosis of an extraocular retinoblastoma, the child is started on 3 to 6 cycles of neoadjuvant chemotherapy. This is a slightly different, it's high dose chemotherapy as compared to the standard dose chemotherapy that is being used for intraocular retinoblastoma. And after 3 cycles, we reassess on MRI. If there is still we feel that the eye is not amenable to enucleation, we will do another 3 cycles. Very often these children respond by the end of 6 cycles, and the one is able to enucleate the affected globe, and then that is followed by external beam radiotherapy and remaining adjuvant cycles of chemotherapy for a total of 12 cycles. So if you look at the international retinoblastoma staging system, this most commonly we use multimodal treatments for stage 3 retinoblastoma, which is where there is regional extension, either there is overt orbital disease or optic nerve invasion or accompanying preocular or cervical lymph node extension. So this was one study that was done a few years ago at our center where, for stage 3 retinoblastoma cases, ones with orbital invasion, we compared the efficacy of 2 chemotherapy protocols in these cases. And what we essentially did was that one was a 3-drug protocol of vincristine, etoposide and carboplatin. These are the same drugs that are used for intraocular retinoblastoma. And then we compared this with another regimen of a 5-drug chemotherapy where vincristine, cyclophosphamide, idarubicin were alternating with etoposide and carboplatin. Now 5-drug is more aggressive. It is mostly used in South America, and that is where they use it as a part of their standard treatment protocol, but we had been comfortable using 3 drugs, so we thought why not to compare these two. And what we really found was that at 1 year the survival was pretty much comparable for both these groups, but at 4 years the survival was higher for the VC treated group as compared to the group that was treated with 5 drugs. And not only the survival but also the toxicity was higher for the 5 drug. So it kind of validated our own experience of using high dose chemotherapy for 3-drug chemotherapy for these patients. So this is one of the child who responded nicely. You can see here there is a big orbital mass, and this is after 3 cycles of chemotherapy. Really, it's a dramatic reduction. It's a chemosensitive tumor, and here the eye is amenable, the globe, whatever is remaining of it, is amenable to enucleation. And we use this combined approach because it carries the best prognosis. So after doing surgery, then the child is subjected to radiation, and then external beam radiation, and then the remaining chemotherapy cycles. Now this is the stage B3B that I was talking about. That was 3A where there was no lymph node involvement, but here you can see that the child has presented with orbital retinoblastoma, and there is an accompanying parotid and submandibular swelling as well. So the same picture is seen confirmed on the MRI, and also you can see the status of the optic nerve, which you cannot see clinically otherwise, but on an MRI you can see that there is thickening right up to the orbital apex. So again, this child was treated with this multimodal protocol, and you can see how nicely it has responded to this high dose chemotherapy, showing significant reduction not just in the orbital mass but also in the submandibular area. Now coming to stage 4, metastatic disease. As it gets more advanced, the treatment becomes more complicated and the prognosis becomes poorer. So what do we do for metastatic disease? So again, metastatic disease has 2 components. One is the hematogenous metastasis and the other is the CNS extension. Now as far as stage 4A is concerned, it's the hematostasis metastasis. So here this was one child who presented with retinoblastoma and soft tissue mass in the right maxillary sinus, which has caused destruction of the maxillary bone. So CT also, we did not advise CT, we normally don't, but the patient already had a CT with him, and that again showed a soft tissue component in the maxillary sinus with a sunray spiculated periosteal reaction. So again, we had to go for a PET CT because it had already metastasized to the bone marrow, so it's very important to look for distant metastasis. And PET CT showed that not only the right maxillary sinus but also the proximal shaft of both femurs were involved. So clearly it was a case of widespread hematogenous metastasis. So in this case, the team in pediatric oncology, they tried an autologous stem cell transplantation for this patient, and this is the procedure. I will not go into the details, but this is how they actually did a stem cell mobilization and did some conditioning with chemotherapy, harvested the stem cells, and then infused them again under aseptic precautions. Now this is the post autologous stem cell transplantation. This is a picture 6 months later showing no metabolically active lesion. Now this was almost like a miracle for us. Even we were not expecting this kind of a response, but it was very encouraging to see that even children with hematogenous metastasis can respond given the right treatment. But and again coming to long-term follow-up, so all these children have to be kept under long-term follow-up and surveillance. But in our experience, we've been following this protocol for many years now. So this is another child 7 years later. You can see the right eye having a prosthesis because he had presented with extraocular retinoblastoma 7 years ago. He was treated with this protocol. The left eye is having good vision. So these children are able to lead a near normal life with good quality. So I mean, there is always hope, and one should always try to offer the best possible treatment to these children rather than just telling them that nothing is possible and, you know, just asking them to leave. Challenges do remain, especially when it comes to 4B retinoblastoma, where there is CNS invasion. Unfortunately, people have tried intrathecal methotrexate and other kind of things, but somehow the results have been quite poor. So once the tumor metastasizes to the CNS, then the general approach has been more towards palliation rather than with an intent to cure. And so now this is a study where 149 countries came together to publish their outcomes of retinoblastoma. So now there is this global picture here where you can see. And the main inference was that children from lower middle income countries present with more advanced disease. That is where much of the challenging cases of retinoblastoma lie. And that is where governments should also come forward, and there should be intervention at national and international levels so that, you know, one can promote early awareness so that children can present at an earlier stage, and we don't really have to tackle these kind of cases anymore. So I thank you all, and I thank everyone at the center for all their support. These are some glimpses of our retinoblastoma awareness program that we just had last year, and had a lot of fun with these children. Here you can see they were all engaged in a drawing and painting competition. So all of them have good vision. They're all going to school. They're doing well. So we should always be very positive and hopeful about these children. Thank you.
Thank you so much, ma'am, for that wide variety of cases that you have shown and the multitudinal of the modalities of treatment. May I now call upon Dr. Lomi, sir, for his talk on current perspectives in choroidal melanoma.
Okay, so I will go into my talk. This on current perspective in management of choroidal melanoma. So we know that uveal melanoma is most common primary malignant intraocular tumors in adults, and it's considered about less than 5% of all the melanomas. And why is so much focus here? It's because it is a life and sight-threatening malignancy, and that is potentially treatable if it is diagnosed in time and treated appropriately. Though the cases in our country, in our continent, is less than 1%. However, it's more common in Caucasians, followed by Hispanic and African Americans. We can classify it into anterior and posterior. Most common is seen in choroid at around 90%, and biociliary body 7%, and iris is 3%. So coming to the clinical presentation, most of the time the clinical is presented as accidentally during fundus examination, and or patient may present as blurred visual acuity or parasyndescotoma or progressive visual loss, or sometimes there may be floaters only. So the clinical presentation is can be diagnosed by indirect ophthalmoscope in around 70 to 80%, which can be added. The clinical diagnosis can be added by using ultrasound. It can show a dome shape or mushroom shape or the color bottom shape. This is very pathognomonic. It may be melanotic, and sometimes it can be amelanotic too, and also with or without exudative retinal detachment. So here is a ultrasound B by A scan where you see when you move the cursor of the A vector, we see that on intralesionally you see the mild to moderate and amplitude spike only, and on the right side you see the this very typical the steep angle kappa is there, the choroidal excavation is there, and then you have seen the acoustic shadowing is there, and then you see the homogeneous mass that's arising from the choroid. So this will give you a definite diagnosis of choroidal melanoma. And sometimes you need to do the fundus fluorescence angiography to differentiate with hemangioma again. So in melanoma, you see the early hyperfluorescence, whereas in hemangioma, we see the early and late phase hyperfluorescence. Sometimes OCT can also be used for small melanoma. You will see a serious retinal detachment, debris on the back of cornea, retina, and you'll have a normal retinal thickness and also the intake photoreceptors. MRI is another modalities where you will see a hypo-intense in T2 weighted images and then hyper-intense on T1 weighted images, and also will help to see is there any extrascleral involvement is there or not, or optic nerve involvement is there. And as discussed earlier, PET-CT scan whole body is also one of the role to see, on a baseline, and we all know that liver metastasis is the most common, and also when patient presented to you, literature has reported around 4 persons already micrometastasis has been shown. Sometimes atypical presentation can be occurs. Where you have amyloidotic presentation or multiple lobular lesion is there, or the mass is too big that you won't be able to appreciate whether it's melanoma or some other lesion. Here you can consider for the FNAC also. So what all can be done for this lesion? So treatment depend upon the size, the location, and extent of the tumor, visual status of the affected eye, and also remember of the fellow eye, the age and general condition of the patients, and then their treatment compliances, and also their consent for the treatments. So collaborative ocular melanoma studies have classified melanoma into 3 categories: small, medium, and large. So based on it, the treatments usually is initiated. A small melanoma is 1.5 2.4 apical thickness, and the basal diameter is 5 to 60 millimeter. And medium is 2.5 to 10 millimeter apical height, and then larger basal diameter is less than 60 millimeter, and the large is more than 10 millimeter. And the overall mortality rate is at 5 years. We see that is including both the other cause of death and also because of the melanoma metastasis. 16% in small melanoma, medium in 32%, and large is 53%. Another important derivatives from collaborative ocular melanoma studies have shown and compare with whether you have to go for inoculation, primary inoculation, or brachytherapy. So it shows that in 12 years, cumulative all-cause mortality is 43% in case of brachytherapy arm and 41% in case of inoculation arm. And in case of mortality with histopathologically confirmed melanoma metastasis is seen in 10 years, it is 18% in brachytherapy arm and 17% in the inoculation arm. So these data have shown and provided the assurance that brachytherapy is still at least as safe as inoculation. So there are various prognosis factors which we have already discussed before, like in clinical high risk factor like increased tumor thickness, large basal diameter of more than 15 millimeter, high pigmentation, ciliary body involvement, or anterior involvement, juxtapupillar location, all age at diagnosis, and regrowth after globe conservation therapy. And pathology risk factors are epithelioid cell type have a higher pathology risk factors, and also when its extrascleral extension is there. Apart from that, class 2 tumors are also gene expression profile with class 2 tumors also have got higher risk for metastasis. So for coming to treatment for small size tumor, here's a case with a small size choroidal melanoma, and this patient has been keep on observation, and then we see that this orange pigmentation is over there, and then slowly there's subretinal fluid. So we did consider for using transpupillary chemotherapy in this case. The main treatment for this choroidal melanoma now is plaque brachytherapy. This mainly indicated for the medium-sized choroidal melanoma. So what is it? It is a short distance treatment of malignant disease with radiation immunity from small cell sources. So Stallard was the first ophthalmologist who treated patients successfully with cobalt plaques and proved that earlier assumption, it was assumed that it is melanoma radio resistance, which he have proved it wrong. And there are various radioactive sources like cobalt, ruthenium is there, iodine, 125, palladium, strontium, and cesium was there. In globally now, most commonly used radioactive sources iodine 125 and ruthenium 106 plug. So the source are placed directly into the treatment volume or near the treatment volume. The goal of the treatment is to deliver a curative dose to the tumor while offering the least possible radiation to the other normal ocular structures. The other downgrade of this ruthenium 106 is that it has got very steep dose gradient. That means the near to the radiation, near to the plaque, you have maximum amount of radioactivity will be there, and as we go far away from it, the radiation will go downward. So So it has been found that for apical thickness of more than 5 millimeter, that dose at the apex, which is expected to be like around 80 to 85 gray, is not reaching. So usually for retainer 106, we consider for tumor thickness of around 5 to 6 millimeter. And for this iodine 125, apical thickness can be less than around 10 millimeters, and a tumor dose is usually around 70 to 100 gray. So this another plug, the indigenous plug, the Baba Atomic Research Centers, this is made in India, and we have been using this for the past 1.5 years now. So we have got two shape type. That is notch plug, that is around 21 millimeter. The notch plug is usually used for the lesion which is near to the optic nerve or also near the fovea area to prevent the radiation to affect to that area. And in peripheral one, you can consider for the round plug that is around 15.8 millimeter. So the plug position is very important again. The idea is like the plug should be covered at least 2 mm safety margin should be there. So for example, the lesion, if it's lesion 16 millimeter, the plug size 20 millimeter can be adequate for this coverage. And also for confirming the positioning of the plug intraoperatively, you can consider for ultrasonography or indenting the globe with the posterior edge of the plug and visualize using indirect ophthalmoscope. People in the Western countries have reported the use of trans-illumination, transpupillary or transcleral illumination. But in Indian population, we have got high pigmentation, so we won't be able to see clearly the indentation on effect on indirect ophthalmoscope. So it's a case scenario. This is a choroidal melanoma of 5 millimeter apical thickness. So this is the ideal condition to consider for plaque brachytherapy, and a tumor lesion is just nearby the optic nerve. So here we can consider for the notch plaque, the notch plaque. So this is the post 10 months post brachytherapy. The apical thickness have come down to 2.1 millimeter. So for larger tumors, like if it is more than 5-6 millimeter, what you do? A major concern for the use of retainer 106 plug is that it's a steep dose gradient for large tumor, that the apex dose may not reach the recommended dose of the 85 gray. So we have started considering this sandwich technique, that means on interiorly you can consider for the transpupillary thermotherapy, which we expect that around 2.5 to 3 millimeter it can cover up, and then rest from behind it can be covered up by the plaque brachytherapy. So here is one case of 6.2 millimeter thickness. So here we have considered for the sandwich technique, transpupillary thermotherapy along with the plaque brachytherapy. So in this lesion, after 13 months, the lesion apical thickness has come down to 2.75 millimeter, and we see in melanoma their response is little bit slower. You have to keep on follow up the patients. If in 6 months time, if you see if it is stable, if it is regression or is it progression, you have to find out that one. So the side effect of plaque brachytherapy on eye can be of general extraocular effect, like it may be on eyelid edematous, eyelid swelling can be there, or conjunctival dryness or scarring can be there, or sometimes you're handling with the muscle. So like you can be causing scarring to the muscle, fibrosis to the muscle, or then maybe squint also. And anterior segments, there may be cataract, and there may be glaucoma. Glaucoma because of this radiation retinopathy, and there's release of the VGF, and then they can cause NVI and cause glaucoma also. And also the posterior segment commonly seen is radiation optic neuropathy and radiation retinopathy. Here's one case where after brachytherapy, you can see at 11 months post-op there is a radiation retinopathy was seen with exudation or with the hemorrhage is there with macular edema. So in this case, we have considered for the anti-VEGF using bevacizumab. So the etiopathogenesis for macular edema post-brachytherapy is that the tumor itself it releases the VEGF, and then and the brachytherapy radiation effect it causes ischemia of the tumor and adjacent retina, and they release the VEGF. So combine this effect, there is a neovascularization and endothelial cell loss, and also the vascular leak, which leading to macular edema. So here's one study by Carol Shield et al. And it is published in Retina, which shows the effectivity of the role of OCTA to diagnose that brachytherapy induced macular edema preclinically. So if see in irradiated eyes, we see that the large cystic space macular edema is there as compared with the opposite eye. So what we do in this treatment for such kind of retinopathy, so and also the OCT will show the significant enlargement of the foveal avascular zone and also decrease the parafoveal capillary density in both that superficial and deep capillary plexus in the eyes. So these are the preclinical findings before the patients present with diminution of visions. So the role of intravitreal bevacizumab at 4-month interval has shown that it can prevent the macular edema. Where you see in case with if control in a bevacizumab group where at 24 months there's around 29% of macular edema. However, in case of control group is around 34%. So patient receiving intravitreal bevacizumab demonstrated that there is less OCT evident macular edema, clinically evident radiation maculopathy, and moderate vision loss and poor visual acuity over a period of 2 years. Another treatment modality for choroidal melanoma is proton beam radiotherapy. This allows the delivery of high doses of radiation specifically to the tumor and also reducing the damage to adjacent structures. Studies have shown that at the 5 years that overall survival rates of 70 to 80% and 5 years metastasis-free survival and rate is around 75 and disease-free specific survival rate is around 90%. So another modality is gamma knife therapy. So gamma knife therapy can be indicated for large size non-feasible for plaque brachytherapy, or the mass is over the optic nerve. So you won't be able to place the plaque over the optic nerve. So this size cases, and also the young adult with very huge mass and the vision. Patient is a young adult, so I want to spare the globe and will try for the radiation therapy or explain visual prognosis. You can consider for for gamma knife therapy. So studies have shown that the low dose, because it gives a low dose 21 to 25 gray, so this shows that around 91% local control rate has been shown, and the metastasis is seen in around 2.4% only. So here's one case where it's a steps where you can do the gamma knife therapy. It is done under along with the neurosurgeon people. So the frame, fixing of frame has been placed by neurosurgeon, and what we do is we do and give the block to in the eyes, peribubble blocks, and also to fix the muzzles over the frame, so that during the procedure time, which will take around 1 to 2 hours times, so the eye movement should not be there. So this is the process where the gamma knife therapy has been done. So his case scenario, this case with mass just overhanging this optic nerve, and then also there's retinal detachment inferiorly. So this post gamma knife therapy nearly about 2 years. You see there is a reduction on the mass. Also the retinal detachment have gone. The vision, however, the vision has gone down, but there's a globe salvage is there. Another case with a mass just overlying the optic nerve with apical thickness 6.5 millimeters, and this is the 11-month post gamma knife therapy with apical thickness coming down to 3.1 millimeters. So you see the good tumor control over the years. So what are complications for gamma knife therapy again? So it is like executive retinopathy, neovascular glaucoma, radiogenic retinopathy can be there, or vitreous hemorrhage can be there. So for very large choroidal melanoma and then patient, for that one we can consider for the enucleation, which can also give a very good cosmetic processes. Other surgical intervention are pars plana vitrectomy and endoresection for posterior choroidal melanoma, which now we rarely do that. And also you have got transscleral choroidectomy for tumor too thick for radiotherapy, or also for orbital exenteration for cases with widespread orbital extension. So for case of choroidal metastasis, sometimes it is a case of a young female of breast carcinoma, which have shown with a choroidal metastasis. So in this case, on autofluorescence also you see the choroidal lesion here. This patient has been considered for the systemic chemotherapy for the breast cancer. However, for this choroidal lesion has been considered for external beam radiotherapy, and we see the very good response on ABRT also. So to summarize, the treatment strategies will depend upon whether tumor is small, medium, or large. For small, can observe or do TTT or brachytherapy. For medium, plaque brachytherapy is ideal modality, or can consider for combined plaque brachytherapy with TTT, or gamma knife therapy or proton beam therapy, depending upon the availability. And also for large one, you can consider gamma knife or proton beam therapy, or go for primary enucleation. So further outpatient care, irrespective of treatment model is chosen, you need to have a good patient needs careful observation for follow-up for years, initially 3 monthly measurement of dimension of tumor on follow-up. If no changes are seen, then you can consider 6 monthly follow-up, and then if it growth of lesion is detected or if progression of lesion is there, you can consider for other further modalities. And all on yearly PET CT scan whole body may be helpful for early detection of distant metastasis. So there are some future perspective. There's no current treatment as such to improve the overall survival of the patients. That's why the highlighted need for new strategies for potential therapeutic targets. Immunotherapy is one thing that is most promising therapeutic approach now, and the treatment using nucleic acid is another novel approach that has also been shown promising results in preclinical studies. However, translation into clinical meaningful strategies is yet challenged by the toxicity, poor pharmacokinetics, non-specific uptake, and unwanted immune responses. So the take-home message is, despite all recent advances in the treatment of metastatic diseases, early detection and treatment of tumor before they become metastatic remains the primary goal and has the potential to heal the uveal melanoma. Thank you all for your patient hearing.
Thank you so much, sir, for this comprehensive talk. So I had this question for the audience as a whole, and for people who practice in private. So you mentioned about the indigenous plaque. So how can one avail the plaque for doing plaque therapies in the private practice or in some institutes there?
Yeah. This is you have to go and undergo a process, and this is Atomic Energy Regulatory Board, AERB board is there. So you have to apply for that one. Online application is there, and then through that, once you get a clearance for AERB, you need a process. You should have a specific limitation and the guidelines are there that you should have a radiation oncologist, you should have a radiation safety officer, the medical phases to be there. The area where you are going to do the plaque brachytherapy is to be regularized by and approved by the ERB guidelines. So after that only, and moreover, you have to train ocular oncologist. So after that only you can procure and do this use this BRC plaque. It's very cheap, not very expensive one, but the guidelines have to be cleared before procuring or to start using for BRC plaque.
Thank you so much, sir. Any more questions? Please.
Yeah. So shifting from enucleation to gamma knife therapy and proton beam electricity, are there any long-term studies if the tumors come back or did they develop mets? These patients, were they fine on long-term follow-up? For large tumors.
For very large study and long-term follow-up is yet it is still not there. Only thing is like we have got this COM study where you have enucleation versus radiation. So this is also gamma knife also is radiation only. So you won't get any difference between primary enucleation or going for radiations. Only thing is that there is a growth preservation is there, and sometimes you get then visual preservation is there. Yeah.
Thank you so much, sir. So before we break for the lunch, the last talk for this session is by Dr. Pallavi Singh. She's an alumni. She recently completed her fellowship in ophthalmic plastic reconstructive surgery under Dr. Robert Goldberg in Juleston Eye Institute, UCLA, California. She's here for a talk on lower eyelid blepharoplasty pulse.
Thank you so much, Sahil. It feels really nice to be back home. I see a lot of familiar faces, and I'm going to try and be as concise as possible. I know everyone's hungry. So I'm going to talk about lower lid blepharoplasty pearls, and I'm going to try and keep this a very practical talk for a lot of people who do blepharoplasties already or who want to do blepharoplasties. So we're briefly going to talk about the relevant anatomy. We're going to talk about patient selection. What are the patients that are ideal candidates for this? And I'm just going to talk about the fat repositioning technique. So all of us have seen this diagram a lot. Whenever we talk about fat pads in the upper and the lower eyelids, you see the 2 fat pads in the upper eyelid and you see the 3 fat pads in the lower eyelid. But this is 2-dimensional thinking. But the orbit is 3-dimensional. That is one thing we need to understand. So I think what is important is to realize the relative positions of the fat pads in the orbit. So here we have the inferior oblique muscle. We know that it is between the medial and the central fat pad. And so the medial fat pad is medial to the inferior oblique muscle and slightly deep in the orbit. So whenever you're trying to expose that, you want to make sure that your scissor tips or whatever your instrument of choice is kind of deep in the orbit, you know. The second thing is the lateral fat pad. Now you see here it's almost next to the inferior orbital fissure. So when you're trying to address the lateral fat pad, what we don't realize is that it's pretty deep inside the orbit and it's kind of high. So you want to make sure that you're, you know, pointing your scissor tips in the right direction to be able to get it out, because otherwise you're going to keep looking for it and you're not going to find it. So that should be what the, you know, direction of your scissor tip should be. On the other hand, the central fat pad is pretty anterior. It's quite superficial. So when you're trying to release the central fat pad, what you want to do is basically just point your scissor tips more anterior and just push the orbicularis up, and then it just kind of comes up. You know, lift the orbicularis up, and that's going to give you exposure to the central fat pad. So, you know, that is what we see in the diagrams, but it's important to realize what the contour of an orbital fat prolapse is, and this is what it looks like. It becomes more prominent when you ask the patient to look up. So whenever you want to do the surgery, you want to make them look up so you can really see what the contour of the orbital fat is. And this is just basically imprinting what we just saw onto an actual patient picture. You have the inferior oblique medially, and you have the arcuate expansion laterally, and you have the medial, central, and lateral fat pads. Again, it's more prominent when the patient looks up. So when we talk about patient selection, what are the patients that we want to do lower blepharoplasty in? First of all, it's a cosmetic surgery, so they should want to do get it done. But you want to make sure that they have orbital fat prolapse. The second more important question, especially these days it's being talked about a lot. Earlier, initially, people would just debulk the fat, but now more and more people are doing fat repositioning. And so who are good candidates for fat repositioning? It's important that the patient has good skin quality. You don't want to have patients with very thin skin. You want to have a good donor site. So the orbital fat, you know, which is kind of like a hill, there should be enough fat that you're able to transpose. If the patient does not really have too much of fat prolapse, you will not have enough fat to transpose it. They should have a hollow below that, because there needs to be a place where you can actually transpose the fat. And the fourth thing is the positive vector. Now, the positive vector is the malar prominence. You know, so patients with a very prominent eye, or patients where you don't have as much of a prominence of the malar eminence, they tend to have a higher risk of retraction. So you want to make sure that you're choosing your candidates you know, smartly when you're trying to do a fat repositioning, because it's a longer procedure, it has a higher learning curve, a steeper learning curve, and then, you know, higher risks post-operatively as well. But if done in the right candidate, you know, you can have really good results. So like I said, you have to be beware of thin skin. This was a patient in which fat repositioning was done, and she had really thin skin, so she ended up looking worse than starting out because she just had these bags that were kind of prominent. The last thing, which we don't really think about as much because we're ophthalmologists, but if someone's coming to you for periocular rejuvenation, one of the things you really have to think about is the skin. So there's a large amount of things that you can do for the skin. You can do peels, glycolic acid peels. You can also do a skin pinch. Like you see, this is a Caucasian patient. He had a skin pinch done at the orbital rim. But I think in the Indian population, you can do a skin pinch which is subciliary because the scar hides better. So I think it's a better idea to do it subciliary. And the third thing, if done well, it really gives good results. The third thing is, and you see it a lot these days, everyone's talking about skincare. If you open your Instagram, everyone's talking about a 9-step night care routine. But just asking your patients to use retinoic acid really helps with, the fine wrinkles. So I think in general, if you're trying to develop an aesthetic practice, it's important to not just look at the surgery, but look at everything, because a patient is coming to you to look better, so you want to give them that solution, not just the thing that we know to do. All right, so I'm going to be talking about repositioning mainly, because debulking is just, the first couple of steps of repositioning essentially give you what fat debulking is like. Now, this is a diagram which talks about the hill and the valley that I was mentioning later. You have the hill, which is the orbital fat, which is prolapsing, and then you have that tear trough of the valley below that. And so you really want to reduce the height of the hill and fill up the valley, and you just want to make that whole contour smooth. And you can use that, you can do that using fat injections, or you can just move that fat from the orbital, from that area of prolapse to the tear trough. Now, where to place this orbital fat, people, there's either you can place it subperiosteally, which is under the periosteum. The second place to place it would be suborbicularis, or in the roof, in the SOOF fat plane. Both of these techniques have their own advantages. I feel like the subperiosteal dissection is more difficult because you have to lift up the whole periosteum. It's pretty extensive, but it's more dry. There are lesser chances of nerve damage. But you can also do a suborbicularis. You can place the fat in the SOOF area, which is it is an easy dissection, might provide better viability of the flap here. So this is essentially, I'm going to show you a video later, but what you do is once you expose the fat pads in the lower eyelid, you make an incision at the arcus senilis. You can use either a periosteal dissector or you can use a monopolar cautery, and you just lift it up, and then you basically make fat pedicles. You're just creating fat pedicles, and you just kind of push that down into that pocket you've created, just to sort of efface that, hill and valley that we were talking about earlier. So just gonna play these videos here. So you make an incision about 4 millimeters below the tarsus, and the incision has to be all across the conjunctiva. It has to be all the way down to the punctum medially and to the lateral canthus. And you can see how you can, already start seeing the fat pads over here. And then you just kind of do a bit of a blunt dissection just to release or reveal those fat pads. And it's at this time you have to be cognizant of, the depth. Like this is the central fat pad, it's pretty anterior, so you're just lifting the orbicularis up, and you can sort of expose the central fat pad. For the lateral and the medial fat pads, you have to do a deeper dissection. Also, when we're trying to reposition, we usually reposition the medial and the central fat pad because that's the area where the tear trough is most prominent. Laterally, you don't really need to do it. Okay. Once you've exposed the fat pad, what you do is just you expose the arcus senilis, like what I was talking about. Just you make an incision, and then you create a pocket. The pocket can either be subperiosteal, like we said earlier, or it can be suborbicularis. You really need to do these sweeping movements to create this pocket where you're going to place your fat. It's important to make this pocket because the better it is, the deeper you can take your fat. You don't want to transpose your fat too superiorly because that just, takes away the whole point. So you can see the arcus over here. And once we've done that, we create these fat pedicles. So you can see that's the inferior oblique between the central and the medial fat pads. And what you're basically just doing, all of these fibrous attachments, you're just separating them. And you want to make your pedicle pretty mobile because you want to make sure that it goes right down to the pocket. If it's not mobile enough, you can cause lid retraction. But also you want to make sure that the pedicle is not too thin because then it won't have any blood supply. And once you've made these pedicles, you can use either a double-armed suture or you can use a single-armed suture, permanent or like a non-absorbable or an absorbable suture, depending on whatever your preference is. You tie a suture at the medial end and at the lateral end just to make sure that you have, you're holding both the ends of that pedicle. And then you just kind of pull that fat pocket into that, pull this fat pedicle into that pocket you've created. So you'll see once you've passed both of those sutures, and you want to make sure that you go beyond that tear trough area so you can fill it up. So you can see how that gets pulled down, and you're basically just pulling all of that fat down. You do the same with the central fat pad. Pull it down. Then you just basically tie the sutures. You can either take these sutures off usually at 1 week. That's more than enough to form these adhesions that we need. That's that. So getting back to the presentation. So if done well, I think it gives excellent results. It does have a steeper learning curve as compared to just debulking. Now talking about debulking, you know how we created those pedicles? When you're not doing a transposition, you just kind of excise, debulk those fat pedicles and you'll get whatever result you want. So to summarize, the lower eyelid contour is characterized by you have the fullness of the orbital fat, and then you have a hollowness below that, the hill and the valley that we were talking about. Also with age, there's a lot of skin deflation, there's loss of elasticity. And I think whenever you're trying to do this surgery, it's very important to understand the three-dimensional anatomy. As a surgeon, it's very important to think 3D and not to think 2D. So, you know, just to see the skull to sort of realize where the fat is going to be. If you just debulk the fat, that's going to reduce the bulge, and in a lot of cases, just that is enough. But when you have an adequate donor site, when the skin quality is good, and there is a significant hollow below that fat prolapse, I think transposing fat is a very good option, which you can start using. And I would like to thank Dr. Goldberg, my preceptor, who taught me a lot about lower blepharoplasty. And I would like to thank everyone at RPC. This is us in 2018, and it feels really good to be back. Thank you, everyone.
Thank you so much, Dr. Pallavi. Would Dr. Prajad sir like to add something to this?
Yeah, so that was a wonderful presentation by Pallavi, and we would also like to know about some of the, non-invasive techniques that they are using. Dr. Goldberg especially uses like fillers for lower eyelid retraction, etc. Just a brief, what all is being tackled by using fillers, because lately they've become quite fond of using fillers for almost
everything.
Right.
Anything. I mean, there's like an orbital tumor, and we joke about how you just put filler inside it and it'll vanish.
Yeah. So
but
can you just?
I think in some situations, the problem with fillers over here is the cost. But if cost is not a problem, I think as a temporary measure, it works for some cases of post-operative lid retraction, where you just want to supplement the anterior lamella. So you can do layers of filling. I think doing just one layer of filler doesn't help, but you do one layer and then you watch them for a month and do another layer. So just to build up that anterior lamella instead of doing a skin graft. The other thing where we use it very commonly is eyelid retraction for thyroid eye disease. We just put filler in the levator plane, and that just kind of makes the levator drop. So that is also a good temporary measure. It is not a permanent measure, but for some patients who don't have very severe disease and just have this and want something temporary, I think it lasts for about a year or 2 years, so it's pretty good in the levator plane. So we go through the lid crease, so just on top of the levator, like, so you want to go in between the levator and the fat, kind of like that. So you go straight ahead into the lid crease. That's also one of the things. And one of the advantages of doing filler, especially for these things, is that it can always be dissolved using hyaluronic acid, Hyalase. So I think if patients don't like the results or something, you can always move on to something more permanent. So I think that and ichthyosis, like for patients with congenital ichthyosis, sometimes these are really small babies who are very sick, who are in the NICU, and you really don't have any option. They have poor eyelid closure, they have bad lag of thalamus. So for them, I think he's got a good series where he's just injected filler in the anterior lamella, in the upper lid and the lower lid, and that just helps to improve the lag of thalamus. So a lot of cases of retraction, I think fillers tend to do really well.
So what about inferior retractors when you are doing the conjunctival approach, fat repositioning or removal?
So, ma'am,
because that also comes in between.
Right,
So
the
what do you do
retractors
with
would be
that?
behind. The retractors would be posterior. Because the fat would be anterior to this, which is why when you're doing the repositioning, it's very important to release the pedicles. That's what because if you've not released the pedicles enough and it's still attached to all the soft tissue, when you pull the fat down, you're going to cause lid retraction, and you do have a higher risk of lid retraction with fat repositioning. So you've got to be careful and just make sure that we really release the pedicles. Should be really mobile before we pull it down. So that's one of the things that we do.
Thank you so much
That
for this
was really
wonderful
nice,
talk.
Pallavi. Thank you.
So we may break for the lunch, and after the lunch we have this hands-on session on implants, instruments, UBM, CT, MRI, and TT. Thank you.
with
So
all the
if all the together, we can have a picture before that, before breaking for the lunch. Everyone. I would also like to invite Dr. Lomi sir to felicitate our unit chief, the chief of ocular oncology and oculoplasty. Everyone for the group photograph, please.
including our residents, everybody, come on. से ले लो एक थोड़ा साइड से लेना जिसमें ये आ जाए पीछे बैनर भी आ जाए वर्कशॉप नेक्स्ट जनरेशन we never get to see them.
लाओ मुझे दो मुझे दो मुझे दो
So after coming back from lunch at 2 o'clock, we will be having a hands-on session. I would request all the delegates to come back. We'll be dividing into batches of 4, depending on the number of delegates and attendees we have, and go to the various stations for the hands-on. So I would request everyone to come back, assemble back here at 2 o'clock. Thank you so much.
से बंद